Let's move on to the first session. And I would like to invite the chairpersons, Dr. Ramakrishna Pillai, Dr. Velayudan CC, Dr. Girish GK, and Dr. Praveen GL onto the dais, please. Let's invite the chairpersons onto the dais with a very big round of applause, dear everyone. Please. And dear speakers, please note, you just have 9 minutes for the presentation and rest 3 minutes will be for the question answer session. Please note, you just have 9 minutes for the presentation. Thank you.
Good morning, dear friends, colleagues. So we'll straight away start the scientific program. First program is diet advice to my patients after acute coronary syndrome. What is latest in 2023? Dr. Abhilash will be talking on it.
Yeah. Thank you, sir. Good morning, respected chair. I would like to thank the organizers, Arshad sir, Vinod sir, and all the organizing committee members of ICC-CON for giving me this opportunity to start the innings on day one. Thank you, sir. We'll move to the presentation. Diet following acute coronary syndrome. We all know the importance of diet. Actually, we live, of course, diet. We also actually, every day we work to get the right food, the balanced food, and of course, the delicious food as well. And then suddenly the heart attack stuck. And the patient is upset. Now he is restricted for what to eat. Definitely he's going to ask us what can be eaten. The good thing is, as we see here, he can actually continue to eat almost all the food items. There are big variety of food items available. Having a heart attack does not prevent anything. But the motto is, identify the real harmful ones, continue to have the good ones, then probably most of the things in moderation. We'll see what all this. The talk is based on ACC/AHA guidelines 2021. There is no further update on it. And then there are a few gray zones. Then there are consensus and a few practical aspects as well. Diet following ACS, of course, should reduce chances of one more attack. Help reduce cholesterol and blood pressure. Help to reach a healthy weight if overweight. If proper weight, we should maintain the weight. Losing too much weight is also not a good thing. And it should reduce the chance of developing diabetes. And if already has diabetes, it should control. And the patient should feel healthier. He should have more energy. He should not be upset. The mental insult by the disease itself is a burden. We should not add to that trauma by too much restriction on diet as well. So starting with the energy itself, that is the cornerstone of most of the new guidelines. Too much of energy is the problem. Energy means calorie. The net calorie intake should be for the weight and the age of the person. We should remember that beyond, say, third or fourth decade, our calorie requirements comes less, 100 per day, 100 calorie per day per decade. So even if you calculate based on body weight, we need to adjust it to the age as well. We know that 1 gram of carbohydrate provides about 4 calorie and 1 gram of fat provides about 9 calorie. So if you eat 2 grams of carbohydrate, that nullifies the benefit of avoiding fats. So optimal calorie is the strong guideline support and we have to build upon. Calculate what is the calorie requirement for that patient and advise according to what the calorie intake per day to maintain an optimal body weight. There is no ambiguity, there is no question. All guidelines, all consensus are agreeing on this aspect. Fruits and vegetables. 40 to 50% of the dietary intake should be vegetables and fruits. They say 4 to 5 portions per day. At least we take roughly around 3 meals and at least we can ensure that 3 portions of fruits and vegetables are ensured. Maybe the fourth one, snack, which is many a time a useless or in fact a dangerous oiled processed one, we can actually add a salad as the fourth one. So fruits and vegetables, no ambiguity, we should encourage. Then regarding the carbohydrate intake, use whole grains with enough bran. The too much refined rice or whatever cereal they are using should be restricted to, or preferably they can have actually whole grain, and the sum total should be around 25% of the total diet only. So you need to reduce carbohydrate to 25%. And what we are actually often forget to miss is this one. Proteins, that does not add much to the calorie. The protein they suggest is protein from the plant sources. We have, of course, chicken, the white meat, but the guidelines prefer plant source proteins. We have all the legumes. Actually, one advantage of the legume is we can have that as a snack at 4 o'clock, if you know to avoid a oil-based snack. Nuts and seeds are encouraged, but with respect to nut, what we have to remember is the total calorie intake should be ideal for the patient. Then, there is no ambiguity regarding fish as well. We can encourage the patients, if he is a non-vegetarian, to have fish. Fish has definitely proven to have cardiovascular benefits. Only thing is, the oil added onto the fish is the problem. The oil which comes along with the fish is okay. So we should not process the fish with too much of oil. Deep fried food items should be avoided. Then another question we come across every day is whether we can use dairy and egg. The recommendation is low-fat milk, but when you delve into what made to the recommendations, there is not much study to prove that low-fat or a normal fat can actually change anything. But the recommendations stick to low-fat, so I added low-fat milk. Then low-fat dairy products, they are permitted. And egg, again a controversy thing. I think the current guideline does not oppose having moderate use of egg. Maybe 1 egg or 1 egg per day or 2-3 egg per week should be okay. Poultry, again, if the patient is non-vegetarian, this could be a good source of protein, in fact, much cheaper than the plant-based proteins. So they can have chicken. Again, you should not over-process it, should not add too much oil into it. Any deep-processed or multiple processed food items are a no. Then, of course, then the question will come whether they can have red meat. The guideline, in fact, Western population, I don't think it is practical for them to avoid red meat. So the guideline is choose lean cuts and avoid processed, over-processed, like the pepperoni, salami, those things. Avoid it and use the minimal prepared one, but of course, in moderation. For our patients, I think we have like the chicken and vegetarian meals are good enough to supplement most of their needs. We can tell them that it's better to avoid. Then the question comes oil. This has been a debate for many decades. The guideline says polyunsaturated fatty acids, like the plant-based oils are good. The topical oils, like coconut oil, are bad, but it's a debate. Maybe our advice should be to restrict the oil to minimum. We need not prove anything by ourselves, testing on ourselves. Maybe all the oils to be minimum. The recommendation is to use a plant-based oil. Then the question, the blood pressure control, how much salt we can. No extra added salt is the recommendation for those with hypertension. But at least, it may not be practical to our patients to avoid salt always, but they can avoid salt-rich pickles and salt-rich appalams and those things. And of course, the snacks like the chips and all. All these contain a lot of salt, added salt. Sugar, I told you, even though the fat gives 9 calories per gram, carbohydrate gives 4 grams, so twice that quantity. It's almost equal to eating fat. The liver converts the sugar to fat in the body. So sugar also should be in moderation, even if the patient is not a diabetic. A strict no to carbonated beverages with sugar. Even each 100 ml contains too much of sugar when we look at the label. I missed that, but that is a recommendation. Then this slide, which when I was thinking after preparing this presentation, many of things are actually I too like. But unfortunately, all the fast food, processed food, they call junk food for a reason. We should advise the patient not to have it. I'm sad about it, but that's the truth. Over-processed, fried food items. Then the question is alcohol. Patient is many a time concerned. If he is not an alcoholic, that's not an issue. But if he is already on an alcohol, what's the recommendation? I think our recommendation should be to avoid it. That's the best time to counsel them to stop it. But if you delve into the recommendations, ACCHA says, if you do not drink alcohol, do not start. If you choose to drink alcohol, limit intake. The recommendation is 1 drink per day for females and 2 for males. This is the sum total of what I presented. Time is up. So a practical advice I tell in the OP is, whatever we used to serve in the main plate, serve in the side plate, and whatever you used to serve on the side plate, bring it to the main plate. That summarizes the carbohydrate to 25%, fruits and vegetable to 40 to 50%, and proteins to another 25%. Thank you.
Abhilash, very nice. You have made a beautiful presentation of a very important and often neglected topic. When we discuss diet with patients after ACS, they often ask about four things. One,
Yes.
eggs. Two, ghee.
Yes, sir.
Then coconut and coconut oil.
Yes, sir.
Any comments on these specifically?
Sir, coconut oil is a controversy. There are people arguing for it, but the current evidence and guidelines are against it. Personally, my advice I would tell to the patient is minimize all oils, not only on coconut oil, all the oils for that matter. If they want to use oil, I generally encourage, say, plant-based oils or like olive oil or sunflower oil. But in general, it's not practical, sir, because we have evidence supporting coconut oil on the other side. But based on strict guidelines, we can keep it as minimize the oil use. Then egg, current recommendation do not say, in moderation can be used. Then only one thing about oil is they should avoid reusing of oil. That has data. It increases saturated fat to greater extent. So many of reusing oil is they may avoid in the home. But the problem is many of our bakery products, chips, snacks, they're all going to be cooked in the recycled oil. So we can give that advice that those things are used with the recycled oil, better to avoid.
How would ghee, the
Sir,
potential
I think the
benefits of ghee have been highlighted?
recommendation is no, sir.
The
No.
potential benefits of ghee have been highlighted recently.
Yes, sir. But the guidelines do not support.
Dr. Abhilash, opening batsman, you have done a good job.
Thank you, sir.
Anyway, you made it quite simple. So always this dietary concern is a big concern post ACS. Many of the patients used to say that they are keeping starved because they are not, family members are not giving any food to them.
Yes, sir.
Anyway, you have correctly told, even red meat also you told it can be taken, should be taken. So it should be a healthy diet that we should
Healthy diet.
take.
Everything in moderation, but strictly avoid the harmful ones. Harmful ones are the over-processed foods, reused oils, and excessive intake of anything. All other things in moderation are good. Fruits and vegetables and fish are encouraged.
Yes. Yes, nice presentation. Thanks.
Yeah, thank you, sir. Green leaf fever. Yes, sir. Guidelines actually says both about green as well as white. They preferred are green, yes, sir, with more flavonoid, but they say even the stored, in fact, guidelines say, ACC says, stored plant foods they are as good. In fact, some of them have more nutrients and they are cheaper than the fresh ones. So the cost also comes into the picture. They say stored vegetables are okay. Okay. Yes, sir. Yes.
Dr. Ramesh Natarajan, please come.
Good morning to you all. Respected chairpersons and dear friends, I thank Dr. Arshad and Dr. Binod Thomas for giving me this opportunity. So, there's a surge of sudden cardiac deaths in the community, and the topic given to me is whether CT angio, doing a CT coronary angiogram, will help us in some way or to reduce the incidence of this particular problem. So these have been in recent times several young people dropping dead due to cardiac arrests in the prime of their career and life in the 30s and early 40s. And recently we have had this patient, a 48-year-old, who presented with anterior MI cardiogenic shock. His only risk factor was a family history of premature coronary artery disease. The infarct-related artery was occluded, definitely, but look at the disease in the other vessels. And he underwent bifurcation stenting on IABP support, and while he was about to be shifted, he had cardiac arrest, prolonged resuscitation, and ended up on ECMO. IABP was on multiple inotropic support, and I had a stomy cause sepsis, and finally he's on the road to recovery. So the basic striking thing in this particular patient is the extent of disease in the other vessels, the dominant circumflex, the large ramus branch, the diagonal, and this was totally undetected until he had this massive myocardial infarction, and which brought us to notice the disease in the other vessels. So the basic questions before us: what causes these sudden cardiac arrests? How to detect coronary artery disease in the general population early enough so that we can institute preventive measures in a focused manner to those who have anatomical coronary artery disease. The risk scores which are in use, the systematic coronary risk evaluation, or the Q-risk, or the pooled cohort equation, which have been in use basically for studied in large populations, to whether they are useful really. Is functional testing like the treadmill or the SPECT enough to detect these candidates who are likely to develop such events in future? Coronary calcium scoring, what is the current status? The role of coronary CT angiogram, the topic of today, in the early detection of CAD, what's the data? And whether it is recommended in the asymptomatic subjects. So in the next 8 minutes or so, I'll try to answer some of these questions. So basically, as we know, the coronary artery disease is the commonest cause for premature and avoidable death. And effective low-cost treatments, especially the lifestyle changes, the statins, use of antiplatelets, they can prevent the acute coronary events if they can be started sufficiently early in the eligible candidates. And for that, you have to detect the coronary artery disease in these patients. So the risk scores which are in use, they are basically, they were developed in older populations and were designed to predict MI, stroke, or death after 10 years. But with the data, the Swedish data, the SCAPIS trial has shown that with the help of coronary CT, we can detect a high prevalence of subclinical coronary atherosclerosis in much younger subjects. And by detecting this at the early stage of development, it could potentially identify subjects who would benefit from a preventive therapy to reduce future cardiovascular events. So the current techniques of coronary CT is pretty well standardized, just 60 to 80 ml of IV contrast, a breath hold of 5 to 10 seconds, and ECG gating is done to equalize for diastolic equalization of the images. Procedure duration hardly takes about 15 minutes, and you get excellent images. And the most important thing is the 99% negative predictive value for obstructive coronary artery disease. So why coronary CT angiogram? If you compare with the other modalities which are available for detection of coronary artery disease, the exercise ECG, stress echo, the perfusion imaging, etc., if you see the coronary computer tomography angiography, the sensitivity is close to 100% with a close to 90% specificity. And whether it is the low radiation dose protocol or the standard one. So this recent data, again, which came in from a Danish cohort, about 9,500 asymptomatic patients who are more than 40 years of age. They underwent the coronary CT, and which was classified as having obstructive or non-obstructive, as well as extensive or non-extensive. And what they found was quite striking. About 46% of these asymptomatic young subjects had evidence of atherosclerosis, of which about 36% was non-obstructive and 10% obstructive. When they were followed up for about a median period of 3.5 years, the death and myocardial infarction was highest in the obstructive and extensive atherosclerotic disease as detected by the coronary CT, almost up to 8-fold. So these data, in fact, help us in improving the targeted preventive therapies in comparison with the risk scores and coronary artery calcium scoring. So we can see that the coronary artery calcium, for example, is recommended by guidelines in persons who are borderline or intermediate risk using the risk scores. But you can see that even those with a 0 calcium score, they have a 5.5% incidence of proven atherosclerosis, and those with low scores have almost 82% evidence of coronary atherosclerosis. So here is one example, a low calcium score of 11 in the LAD in the CT, but the coronary CT in fact shows more extensive disease. And one important aspect of the coronary CT is that it can detect the high-risk plaque features. So here the CT in fact shows more extensive disease with non-calcific and low attenuation plaques here, positive remodeling, spotty calcium. So these are all high-risk plaque features. So even though the coronary artery disease is non-obstructive, presence of these high-risk plaque features, in fact, is a harbinger of significant coronary events in future. So attenuated plaques with minus 50 to plus 50 Hounsfield units, it correlates with the necrotic core identified by the intravascular ultrasound. Presence of positive remodeling, spotty calcification, all these are high-risk plaque features which indicate future coronary events. So these have been tested in the ROMCAT-2 trial, and the presence of these high-risk plaque features, in fact, it predicted the likelihood of acute coronary syndrome in patients who presented to the emergency room with chest pain, but who had very normal ECG and normal cardiac markers. So these are very common sort of patients we face in our practice. Patients coming to ER with chest pain, which we cannot really say it is cardiac or not, but the electrocardiogram is almost normal, markers are negative. So such patients, if we subject them to a coronary CT, we can detect, and if they have these high-risk plaques, those are the subjects who can go on to develop events in future. And if we start preventive therapies in them, that will be a fruitful thing. Here again just demonstrates the positive remodeling which can be seen with the current softwares which are available, and also the low attenuation plaque in contrast to the stable plaque which is seen on the right side. So the incidence of cardiovascular death and MI have been found to be almost 3 times more frequent in patients with adverse plaque characteristics. And of the characteristics, the positive remodeling and the low attenuation plaque, they are most useful prognostically. And most of the adverse events occur in patients who have these plaques located in the proximal segments of the coronary arteries. And the large meta-analyses have shown that the superiority of this coronary CT in identifying stenosis more than 50%, and it has much higher sensitivity and in comparison with treadmill and SPECT. And the ischemia trial, in fact, we know that coronary CT was used to rule out left main disease in patients with moderate ischemia. About 8% of those patients had left main disease. And also, so the COURAGE and ischemia trials have in fact shown that stable coronary artery disease, in patients of stable coronary artery disease, the anatomical extent of the disease is prognostically more important than the severity of ischemia to predict the death and myocardial infarction in future. So there should be a slight change in our practice in that doing a treadmill test may not pick up those who have who are likely to develop an acute event, but the anatomical extent of the disease as shown by a coronary CT may be much more valuable. So these are all some of the trials of the CCT in coronary artery disease, and most of the major findings have been high negative predictive value, high sensitivity, a reduced time to diagnosis and detection of the high risk plaques. If we can take a couple of minutes more. It results in more accurate diagnosis of obstructive CAD in stable chest pain patients. And so this has really given the coronary CT a position in guidelines, in the NICE guideline, ESC and AHA guidelines have given it as a recommendation as a first-line test for evaluation in intermediate to high-risk patients without a known coronary artery disease who are presenting with chest pain. So in these patients, many of them in our setup, they undergo an invasive angiogram, but there are still many patients who are sent from the ER because the troponins are negative, and sometimes we do a treadmill for them. So in such patients, if we can do a coronary CT, it may be much more beneficial in terms of prevention of future events. This Scott Hart 5-year follow-up, in fact, showed that the changes in treatment based on the coronary CT plaque morphology, it has resulted in significantly lower rate of death from coronary artery disease as well as MI in these patients. So, I'll skip that. And the coronary calcium score, again, it is done always as part of a coronary CT study. Initially, we do a coronary score, calcium score, and then proceed with the CT. But even in patients who have a low coronary artery calcium, there is a high chance of non-calcified plaques which are prone to rupture. So, coronary calcium score, in fact, it tells only a tip of the burden of CAD in the population. The potential drawbacks of CT has been, radiation risk. When you apply it in a large asymptomatic patient population, radiation risk and contrast side effects have to be borne in mind. And some cases there is difficulty in interpretation, especially when you have extensive calcium. Blooming artifacts can interfere with the lumen interpretation, high heart rates, morbid obesity. These are situations where you may not get good pictures. So here's an example in extensive calcium. It may be difficult, but there are current softwares have made things easy. You can have a better delineation of the lumen characteristics. Here again, in presence of the stent, the upper picture in fact shows the blooming artifact, but by modification with the current software, you can get a very clear picture of the stent and the lumen. So I'll come to the, so who all should get a coronary CT angio with the intention of prevention of sudden cardiac deaths. Patient presenting with chest pain to the emergency room with a non-diagnostic ECG, negative cardiac markers, and normal echo findings. Sometimes we subject them to a treadmill. So such patients, if they go for a coronary CT angio, it may be beneficial. Patients with multiple risk factors, polyvascular disease, strong family history of CAD, and so maybe as part of a cardiac checkup package, we should include coronary CT in addition to the current available parameters. So thank you all.
Very nice lecture, Ramesh. The last few slides were very important. We really have to choose which patients have to go for this kind of CT coronary angiography.
Yeah.
We can't offer it to everybody because there is a feasibility is a problem.
Absolutely. And in our setting, very often the invasive angiogram becomes much more easier because to get the expertise in the emergency room may be difficult for a CT interpretation.
So you suggest before conventional coronary angiogram, go for this one.
Not in patients who have proven CAD or who are already on, who have CAD presenting with chest pain, you have to go for an invasive angiogram. But those where you are you want to rule out a chest pain, the ECG is abnormal, not very significant changes, markers are okay. So you might subject them to a treadmill, and if the treadmill is negative, you may reassure them. So instead of that, those patients, if you subject them to a coronary CT, you may pick up more of subclinical atherosclerosis, and the benefit would be in our setting would be to start a statin or antiplatelet for them, and more aggressive modification of risk factors.
So in what suspected case of coronary artery disease, you are going to do CT?
Currently, there is no recommendation for asymptomatic patients. So only those presenting with having some chest pain, stable chest pain, where the other investigations are equivocal. So those are the patients where you may benefit from.
Very exuberant presentation, sir. But this coronary CT we have to do for patients presenting to the emergency room with chest pain with negative cardiac biomarkers and ECG changes. Should we go ahead for all patients like that? Anyway, I'm not sure because the contrast load is almost like for a PCI for patients doing coronary CT angiogram.
Yeah.
So that much load we should give to such patients. We don't know. And in the recent past also, lots of demises we came across. All of them, most of them were in good physique and gym going people. So none of them presented with chest pain also. So how to catch up those patients, we don't know exactly. What do you opine about that, sir?
Yeah, so that is the group where currently there is no recommendation available. So that asymptomatic group. So in those patients also, if they are instead of doing a exercise treadmill as part of a health checkup, in those with a family history of coronary artery disease or some other risk factors, if you subject them to a coronary CT, you may find features of high risk plaques and those things.
Okay, thank you.
Sir, will you please conclude the session? We have
Okay.
already exceeded the time too much.
Thank you.
Thank you, chairpersons and speakers. So now we move on to session 2. And I would like to invite the chairpersons, Dr. Shyam N., Dr. V.V. Radhakrishnan, Dr. Vijo George, and Dr. Ranjit R. onto the dais, please. Yes, once again, speakers, please note, please don't exceed 9 minutes for the presentations. And chairpersons also please note, the total time for the speaker is 12 minutes, of which 9 minutes will be for the discussion and rest 3 minutes for the discussion session. Thank you.
Dr. Vinay Benjamin. The topic is multivessel PCA in the young, my approach.
Good morning, respected teachers, senior colleagues and friends. The topic of the day is how to manage multivessel disease in young. So most of the young patients with multivessel disease present with ACS. When you talk about multivessel in this talk, I'll be discussing about patients less than 45. Recently, there is a dramatic increase in the incidence of ACS among young individuals. Let me start the presentation with this story of this young gentleman. He is 34-year-old patient who has presented with acute non-ST elevation MI. 4 years back at the age of 30, he had suffered an anterior MI. The middle AD was occluded. PTCA with drug-eluting stent was placed into the middle AD. Was doing well. Now he has come with non-ST elevation MI. As you can see, LAD is occluded right from the ostium. LCX proximally has got a significant stenosis. And RCA, it's predominantly distal disease. You can see the distal LAD is filling from right coronary artery. And this patient underwent PCI, long stent from osteoproximal LAD and proximal circumflex, was doing well without symptoms with an ejection fraction of 50%. And 4 years after that, at the age of 38, he again came with an acute non-ST elevation MI. This time, the stents, both the stents are patent, can see good flow, but there is extensive atherosclerotic progression in the right coronary artery with significant stenosis in the mid-right RCA. And this patient again, he underwent PCI in the right coronary artery with good result. The distal lesions were left. So what does the data say? In fact, there is not much data regarding the outcome and management of multivessel disease in young. The management of young needs to be clearly elucidated as they have long life ahead, unlike in those patients who are elderly. If you look at the 2021 ACC guideline in stable ischemic heart disease, if the patient has got left main disease, CABG is recommended to improve survival, class 1 recommendation, and PCI is reasonable to improve survival, it's class 2A. In multivessel disease, if the patient doesn't have diabetes, if there is normal ejection fraction, CABG as well as PCI, it's class 2B indication. And if you have multivessel disease with left main, you have preference for going for CABG over PCI, it's class 1, whereas PCI is class 2. So most of these data come from trials like Syntax trial, where first generation drug-eluting stents were used. And median follow-up is around 5 to 10 years. If you look at the mean age of this study population, most of these trials, the mean age is around 65 or more than that. If you compare these young patients with multivessel disease, they are having almost half of the mean age of these study population. So, and they have long life. So can you compare this, use the same data to guide the management in these patients? Actually, there is paucity of data. With difficulty, I could get only one study where, particularly in young patients with left main and multivessel disease, a second generation drug-eluting stent was compared with CABG, less than 45 years. This was from China, Beijing, more than 200 patients, followed up for 5 years. And the study group concluded in young patients with left main or three-vessel disease, PCI showed higher incidence of MACEs, which was mainly driven by repeat revascularization. At the same time, there was no difference in hard endpoints like mortality, myocardial infarction, stroke. These things were the same. Therefore, PCI is an alternative treatment to CABG in young patients in complex CAD. That was the conclusion. Not only that, CABG has got some concerns. If you go for total arterial revascularization, it is associated with improved survival and reduced reintervention compared with a single internal mammary artery with saphenous venous graft. Routine use of RIMA and radial artery is not widely adapted. If you have to go for total arterial revascularization, you have to go for RIMA and radial artery. But because of various reasons, this is not widely adapted in most of the center. Although LIMA has got good long-term patency, vein graft degeneration is very common beyond 5 years. SVGs, they typically develop accelerated atherosclerosis resulting in high morbidity and mortality. So 15 years down the line after CABG, almost 62% of the patients will have recurrent angina. Hence, it is essential to consider the risk-benefit ratio of these procedures beyond 10 to 15 years. See, after 10 to 15 years, most of these patients, young patients, they are still running the age of 50 or 55. So, still young, they have long life ahead. So revascularization, see, suppose there is a graft failure. In case of graft failure, either they have to go for PCI or CABG in most of the cases. If you are going for PCI after CABG, it is associated with higher rates of procedural failure, complications, and worse outcomes. Redo CABG at the same time has increased technical difficulties and 2 to 4-fold higher mortality than when you consider a patient with first CABG. So all these factors have to be considered in sending the patients before sending the patient for CABG. So what is my approach? PCA should be performed whenever possible in young patients with multivessel disease to alleviate symptoms and if possible, avoid or postpone CABG for advanced illness later in the life. When the patient with multivessel young patient present with acute coronary syndrome, complete revascularization should be achieved whenever possible, since it reduces mortality, morbidity, unplanned revascularization, all those things. So higher the degree of residual untreated lesion, higher the risk of subsequent events. In non-ST elevation MI, patients are generally older, have more diffuse disease, sometimes without a clear culprit lesions. So in these patients, PCI to all lesions are done during the same procedure if the patient is stable with normal kidney function. But in STEMI, PCI to non-culprit lesions are usually staged during the same hospitalization after primary PCI. This will avoid overestimation of lesion severity due to adrenergic increased vascular tone and reduce the risk of contrast. Prompt revascularization, even though not common, of non-culprit lesion along with primary PCI is done if signs and symptoms of ischemia are still ongoing after primary PCI. Functional evaluation. It reduces repeat revascularization mainly by avoiding inappropriate stenting. When functional complete revascularization is achieved, residual angiographic syntax score is not predictive of subsequent events. So in acute setting, should mind that the response of adenosine could be blunted and the lesion severity may be underestimated. So usually it's done 2 to 3 days after primary PCI. So after primary PCI, good diameter stenosis more than 70, go for revascularization. If it's intermediate between 50 to 70, you go for functional revascularization. Significant, go for revascularization. If FFR more than 80, can consider intracoronary imaging. It's used most often in optimizing the results in complex PCI, but it can be used in identifying high-risk vulnerable plaques. But preventive PCI in non-obstructive vulnerable plaques are not recommended and they need close surveillance and aggressive secondary prevention. Hybrid coronary revascularization is an option, particularly in certain cases of emergency PCI after doing PCI in RCA or LCX, CABG to LAD if there are anatomical complexities or if your PCI is unsuccessful. Sometimes during PCI, if there is complication, you may have to go for CABG. Consider minimally invasive CABG. There are certain other strategies which could be relevant in young, like leave nothing behind, vanishing support. So this patient, 28-year-old patient, coming with anterior olame, significant chunk of thrombus in left main. After thrombosection, you get a clean vessel without much significant residual lesion or stenosis. Had a lesion on the right coronary artery, you do angioplasty with a stent there. So here you have done PCI, good revascularization without any stent. And wherever appropriate, you can use drug-coated balloon. So you can avoid stenting in young patients. These can be used in instant restenosis, when diffuse small vessels or side branches like that. Vanishing support using biovascular scaffold is also an interesting strategy. So here after 2 to 3 years, artery regains its neutral state. So this should be very exciting and would be safer in patients who have a longer life, around 50 to 60 years of life left behind after this. So what's my approach to multivessel disease in young? In general, most of the principles are the same, but perform PCI whenever possible, even if the lesion is complex. Complete revascularization in acute coronary syndrome during the same hospitalization. Keep a low threshold for FFR and imaging whenever indicated. No preventive PCI. Avoid, if possible, or reduce the number of stents by using thrombosection, drug-eluting balloon, etc., if the anatomy is suitable. Consider biovascular scaffold in selected uncomplicated lesions, and hybrid revascularization is an option when a LAD lesion is too complex for PCI. Thank you.
Thank you, Benjamin, for the nice talk. You have just mentioned about biovascular scaffold in multivessel PCI. Multivessel PCI, there's increased restenosis. So do you have any data on biovascular scaffold in multivessel PCI in young patients?
See, we don't have any, guideline doesn't support this biovascular scaffold. But considering the long life of this young patient, it could be exciting. But you have to choose the patients. Those patients who are less complicated, type A type of lesions, you can consider using biovascular scaffold. It's not supported by guidelines.
Sir, what will be your approach on a patient, young patient with ostial ramus lesion? It's a 3 mm ostial ramus lesion. There is no lesion anywhere.
In general, I would avoid putting stents in those type of patients because unless it is too big or symptomatic. Most of the times I feel we can, if it's a thrombotic lesion, definitely I would avoid stent. But otherwise, try to manage medically rather than endangering LAD or other important vessels.
Okay. Will you approach DUB in that condition? DUB, because patient is symptomatic, young patient, class 2 to 3 symptoms, not subsiding with the optimal medical treatment.
See, such a scenario is very rare, but in that case, I would attempt PCI there, but I'd be very careful. I would be very reluctant in putting a stent from left main into the ramus, jailing LAD and LCX. So I'd be very conservative in this aspect.
Thank you, Dr. Bindu Benjamin, for the excellent talk. I now invite Dr. Professor K. Shivaprasad, HOD MCS Trivandrum. An infected stent after PCA, how to recognize and treat.
Good morning, chairpersons and my dear colleagues. I'm going to talk about a very rare situation which happens to all the interventional cardiologists. Infected stent after PCI, how to recognize and treat. The incidence is very, very low, less than 0.1%. Probably underreported, probably results in very early mortality. That is why the incidence is not high. It was first reported by 1993 by Gunther in a case of pulmonary heart stent in RCA. And compared to other vascular stents, prevalence of coronary stent infection is lower because of the high flow rate which you achieve in the coronary arteries. Though it is extremely rare, one should suspect this if you have fever in a patient who underwent recently a coronary intervention and yield positive blood cultures. As I told you, it's very high mortality is there attached with the stent infections. It's surprisingly, it is more common with elective planned PCIs than primary PCI. Complex coronary interventions have more incidence probably because more passage of balloons, more passage of wires, more time taken, and you have repeat access through the same site on consecutive days or very close intervals, more common with the deaths than bare metal stent. This is the first report which came in 1993, And this is probably the reason: disrupted coronary endothelial surface, immunosuppression by the dust, and persistently exposed stent struts is a nidus for bacterial colonization. Biofilm formation prevents antibiotic, it acts as a barrier to antibiotic, arbitrarily divided into less than 10 days or more than 10 days and calling as early or late, but this is quite arbitrary. Most common organism which has been isolated so far from the reports are 80% it is Staphylococcus aureus, maybe methicillin resistant or methicillin sensitive, then Pseudomonas aeruginosa in 20% of the cases. This is the schematic diagram in which the old age, advanced coronary CKD and diabetes and hypertension diabetes in a patient who has advanced coronary atherosclerotic along with other adverse features like frailty, sarcopenia, malnutrition, inflammation. You take up for a complex PCI, it may take a longer time. There can be a likely chance of bacterial contamination. Then you may repeatedly access through the same site, which may be a nidus for sepsis when it gets into the stent, then coronary stent infection, and either you have to manage medically or surgically with a very fatal outcome in most of the situations. Challenges are: it is difficult to diagnose unless you suspect it. It can occur very late after the stent implantation, as late as 7 years has been reported. Presentation often mimics any infection in the body, especially we consider endocarditis. How to recognize? Usual presenting features are fever, chills, chest pain following a PCI. It may be within a day or within a week or within 10 days or sometimes later than 10 days. And pericarditis and pericardial effusion is very important manifestation of this. You can also have stent thrombosis, and presentation acute coronary syndrome occurs in nearly 1/3 of the cases, and most of the patients will have a sepsis-like presentation. This criteria is not widely prevalent, but this has been given. Approach is post-PCA status, any presentation of fever and acute pericarditis or acute coronary syndrome, suspect stent infection. Positive blood cultures need to be obtained to make a diagnosis. Echographic features will give you an idea. I will give you some pictures. Features of endarteritis on coronary angiography. Then you can have a PET imaging. Then this is one of the cases which had underwent a right coronary angioplasty, and the patient presented with fever, and on an angiogram, diagnostic angiogram, you can see some small coronary cameral fistula, and fever was there. Blood culture yielded Staphylococcus aureus, but this patient presented 1 month after the stent implantation, initially with pericardial effusion and fever, and patient was treated with anti-tuberculous drugs, but there was no relief. They were investigating and then found out that FDG uptake is there near the stent area. They found that there is a stent with an abs, with stent you can see inside here, and there is a cavity, there is a mass here in the AV groove, and the stent was removed surgically, and the infection was controlled. These are all the courtesy of Reddy et al., which was presented in 2019. Another case of right coronary artery stenting, which presented with infection. Here is another case which came from Netherlands. European Heart Journal published this. They showed a mass in the AV groove, presented with acute coronary syndrome and fever, increased FDG uptake, and finally found out that there is a large infected mass in the AV groove. This is one thing which our dear Rajesh from Calicut gave me. He has a large series, nearly 8 cases, which he is about to publish. And this is one case which he published in the Twitter, which I took with his permission. And this shows the cavity with the stent inside, and this was drained surgically and the patient survived. You can see that this is one patient who has undergone months ago an angioplasty to the LAD, and later on presenting with fever and with acute coronary syndrome, and found that there is a aneurysmal formation at the distal end of the stent, and then subsequently the flow is decreased, and they found that there is bacteremia with Pseudomonas aeruginosa. Surgery was done, and the patient became better. This is a TE examination of the patient, which shows a cavity here in the AV groove anteriorly in relation to the aneurysm which we have seen earlier. These are the various trials which showed this. And to bringing theory into practice, you suspect it, isolate the organism, start treating early. You may be able to contain it very early, but late stages with mechanical complications, you may need to resort to surgery to relieve the symptoms. Even with all these modalities of treatment, nearly 30 to 40% is the mortality. This is the latest publication on this. This came in 2023 from MGR University. Coronary stent infections, a systematic review and meta-analysis of 79 cases. And what has been observed is that in-hospital mortality was the primary endpoint, which is 30%, nearly one-third of them die, and presentations like ACS, fever, or mycotic aneurysms. And they are planning to prepare a predictive model to identify early stent infections. What is to be done? This slide summarizes. Prevention is the best strategy. Any prolonged febrile illness soon after the coronary stenting should not be overlooked. You should suspect a stent infection. Avoid repeated same-site groin punctures because these are the established sources of infection in all the cases which are reported, not a radial procedure. Ensure proper aseptic care and avoid reuse of inadequately sterilized catheters, guidewires, and balloons, especially in resource-poor hospitals. And strict glycemic control is important because immunosuppression leads to a prevalence of more infections. Early arterial sheath removal, there is no role for systemic arterial or antibiotic administration during PCI. So this is an entity which is rare, but if recognized early, you can save the patient. Otherwise, mortality is nearly one-third. Thank you.
Thank you, Shivaprasad, for the nice talk. Let me ask you, what is the preferred investigation if you suspect a stent infection?
There, very early, we can all do is coronary angiogram. Because most of the patients, 38% of them usually present with acute coronary syndrome with the stent infections. So coronary angiogram will give you some microaneurysms, abnormalities in the areas where you have promptly placed a stent adequately in the previous imaging. Compare the previous image, you can identify this. Then you go for a CT angiogram or a thoracic and transesophageal echocardiogram, which will give you mass related to AV groove. Then you can go for an FDG uptake PET, which will give you the site of infection.
Suppose a patient is responding to antibiotic, febrile, and he has completed the course. What is the role of surgery in such patients?
Now, see, early infections where you are able to achieve a control of the fever as well as bacteremia, and there is not much mechanical complication, acute coronary syndrome is already settled, you may end up with a medical treatment alone. Success rate is, you can say, maybe 40-50% the medical treatment in early infections without mechanical complications. But mostly they are methicillin sensitive Staphylococcus aureus. But if it is methicillin resistant, you may have difficulty and treatment may extend up to 6 to 12 weeks.
So I had gone through a case report from Texas Heart Institute. Patient developed sudden cardiac death while in hospital. It was a cardiac rupture from a abscess ruptured into RV, and autopsy showed the cardiac rupture.
One of the cases which I have come across showed an RCA stent which was implanted. 3 stents were implanted for an RCA retrograde procedure, which was a very prolonged procedure, and the patient developed fever after 1 month, presented with acute coronary syndrome, and then the abscess eroded into RV, and the patient actually expired. They could not do the surgery. So that is very well known, you know. That is why you say coronary angiogram is the best investigation, which is very handy. You can do it very first investigation and identify whether your stent is normal or not.
Thank you, Dr. Shivaprasad, sir, for the excellent talk. Thank you so much.
Thank you, dear chairpersons and speakers. Now let's move on to the third session. And I would like to invite chairpersons Dr. Anil Robbie, Dr. Srikala P., Dr. C.B. Isaac, and Dr. Abhilash T.G. onto the dais, please. Once again, let me repeat, dear chairpersons and speakers, time limit for per speaker is 12 minutes, total 12 minutes, of which 9 minutes is for the presentation and rest 3 minutes is for the question and answer session. So please execute it within this time limit. Thank you.
Next topic, section 3, dispelling the myths about nodular calcium in coronaries by Dr. Mahesh Kumar. Over to you.
Morning, everybody. I thank Shashikumar sir for the opportunity, Dr. Vinod for the topic, and Dr. Ashish for making the time convenient. I'll be speaking on calcific nodule, imaging and intervention. So you have to understand the concept very clear. There is something called nodular calcification and something called calcific nodule. So nodular calcification is the least common form of calcification in coronary vasculature. Cannot be distinguished by radiography alone. It's composed of areas of nodular calcification of varying sizes, often accompanied with fibrin with thick, intact fibrous cap. Only when the fibrous cap gets broken up, it becomes a calcified nodule. Evidence of fibrous cap disruption is absent in nodular calcium. So this second part is calcific nodule. This is a nodular calcium with an overlying thrombosis because of the rupture of the superficial layer, initiated through fragmentation of necrotic core calcifications, flanked proximally and distally by intact solid calcium, and seen in coronary arteries which are susceptible to mechanical stress. The more tortuous the artery, the more likely to have this. So this is the principle behind this. So you have a sheet of calcium on one side, you have the sheet of calcium on the other side, and in between whatever is there gets squeezed. How does it get squeezed? It has got axial torque, it's on both sides, it has got a cyclic bending and a shearing strength. So these two hard stones inside which there is a softer area which is squeezed continuously, which causes the rupture. This concept should be understood because in a straight artery, when the rupture takes place, it is just the necrotic core that ruptures and makes it. So when you have two calcific nodules on both sides or extensive calcium on both sides, squeezing in this area in between, causing axial torsion, that breaks up and that causes calcific nodule, and that is the trouble. So if you see the culprit artery in calcified nodule, this light beige color shows the amount of calcified nodule. Culprit artery, you can see in the left main 23%, LAD 4%, circumflex 11%, and RCA 18%. And if you see this side, in the non-culprit artery, there is no calcified nodule. Calcified nodule, because a calcified nodule, the moment the fibrous cap breaks, it presents as an acute coronary syndrome. It is all sheets of calcium and nodular calcium that's present. Various types of imaging, you can choose, pick and choose what you want. The CT, there was a talk on CT which says, you cannot predict the extent of lesion with the CT, but calcium can easily be seen. This is a comparison of histopathology as compared to the IVUS and OCT images. And this is the histopathology, this is the IVUS image, and this is the OCT image. You can choose your choice of imaging. So how does IVUS and the OCT compare when this? So if it's a sheet of calcium with a deep calcium, you can pick up on IVUS. Here you can see a deeper calcium. You can see it with a superficial small white shining with a deep set. This is the only subset where IVUS goes over OCT. There is a thin layer or thin sheet of calcium. The OCT may not pick it up all the time, but IVUS will invariably pick up. In all other forms of calcium, OCT is significantly better as imaging procedure as compared to IVUS. So you have superficial calcium, deep calcium, and nodular calcium. And this is how the superficial calcium looks like. This is how the deep calcium looks like. And this is how the nodular calcium looks like. So everything has to be analyzed and scored in cardiology to give you a hint as to how to proceed with it when you are with the faced with the situation. So in the IVUS classification, you have 0 to 4 scoring. If the calcium is more than 270, but the diameter of the vessel is more than 5 millimeters, then it is 1. 360 degrees of calcium 1, calcific nodule, calcium nodule 1, and vessel diameter less than 3.51. If it is more than 4, you find that if you don't do adequate atherectomy, the stent expansion percentage is significantly less. So if you have calcium and the score is more than 1 actually, you have to use some form of calcium modification to attack this. This is one example. If the calcium score is 1, you can get a stent expansion of 98% without modification. And if a calcium score 3 doesn't get modified, you get a stent expansion of less than 55%. So classification of calcific nodules. They've been classified also. So people have done extensive studies on this. So eccentric nodular calcium that is seen here, pure eccentric nodular calcium is type 1. If you have an eccentric nodular calcium with a sheet of calcium more than 180 degrees on the opposite side, it becomes type 2. If there is a nodular calcium with sheet of calcium on the opposite side but less than 180 degrees, it becomes type 3. Type 4 is when there are multiple hills, multiple nodular calcium, and type 5 is a calcific nodule where it is ruptured. So you have to identify which type. The OCT does help in identifying, even the IVUS does help in identifying this type of calcification. This classification is also done by Dr. Vanderwey in using OCT. So What is the significance? If you do calcified nodule, calcified extensive calcium with calcified nodule, if you don't prepare the stent well, you get stent areas up to 4.49, 4.4, 4.07. This was done later, treated with IVL and re-expanded, you can get the stent areas significantly higher. So preparation of the calcium is preferably done before you put in the stent, but after you put in the stent, there are other methods that's available like an IVL, which can be used for modification of calcium, but what it does to the polymer of the stent is a question mark. This is an angioscopic view compared with the OCT view. Angioscopic view shows like a cauliflower appearance. Before I conclude, I'll just show you one case. This is a classical case of a calcific nodule. You can see the nodule in the center. It can be seen actually as a nodule. It is so difficult that I couldn't even just manage to wire across it. Nothing else would pass through. So treatment of the calcific nodule has to be planned accordingly. So this was done with, initially we did a rota. With the rota 1.4 bar at 170 RPM, we managed to go through the calcific nodule, and it went through rather smoothly, dangerously smooth, but so we took a shot just to make sure that there is no perforation. This was followed up with the IVL. This IVL, this is the newer IVL balloon which has got 120 pulses. Remarkably useful because I could use 80 pulses on the right and 40 pulses on the left, which was equally calcified. So multiple runs of the IVL balloon was done, and this is the result. At this stage, we could take the imaging because before the imaging wouldn't go through. So this is the pre-run RCA. You can see that it's been 360 degrees, 260 degrees calcification from one end to the other end. You can see calcified nodule. There you can see that this is post-IVL, so the nodule has been ruptured, and the calcium has also been extensively ruptured. So this is the pictures which show you the nodule that is there, and the calcium which has been ruptured by the IVL and the rota. So once, this is the morphology, 360 degrees calcium practically, lot of calcific nodular calcium all over. Post-rota and IVL, this is the morphology we got, and we got fairly good results. Unfortunately, we couldn't do the post-stent PCI. The lumen area, we got excellent lumen areas just with the modification with IVL and balloon only. And lesion length was 46. The diameter was 3.4. Everything can be measured extremely well with an OCT. This is the area, the most critical area, and this is a landing thing, and this is a final picture. So if you process and if you treat your calcific nodule well, and if you treat your calcium well, you will have better outcomes with this. So calcified nodule is a form of coronary thrombosis, mainly occurs in older persons, 70 years of age, equal in gender, RCA the most culprit, high prevalence in diabetic and CKD subjects. The lesions may develop proximal to the mid-portions of highly tortuous right coronary arteries. That's the example I showed you. That's the most likely place you'll end up with this. Maximal hinge motion of the coronary artery. The mechanism of fibrous scar destruction, thrombosis through fragmentation of calcific nodular calcium. So there is a break in the cover of the nodular calcium which converts into a calcific nodule and then goes on to become malignant and presents as acute coronary syndrome. Imaging-based PCI is best under these circumstances. Discrete, whatever modification you need to do, you got to select depending upon what the image shows you. Thank you.
Excellent presentation with a lot of points covered. One or two questions. 5% case of the acute coronary syndrome is calcium nodular rupture. And a lot of them, when you do imaging, have thrombus also. So do you directly take them for rotational atherectomy, or give GP2B3A, give anticoagulation for a few days and then let the thrombus settle and then take, or what is the approach? Directly you can?
So it depends on how the patient is. Patient is stable and I'm able to get a balloon through, just give a dilatation and I'm able to get flows. I would prefer to wait for 2 to 3 days and then take him for rota ablation or IVL depending on how much of space is there. So if the patient is not stable, then we will have to do something on the table right then. And it is difficult to do rota with a thrombus sitting there, but it's possible to do.
Can we do orbital, or if required, compared to rota, can we do orbital in some cases?
My experience in orbital has been disappointing so far. Touch wood. I mean, I'm not an orbital fan. Rota whenever feasible. IVL, if I can go through, I'm not a big orbital fan.
Okay, thank you.
Thank you.
Next topic is post-PCA patient asymptomatic but TMT positive. How should I approach?
Good morning. My patient is a post-PCI patient, entirely asymptomatic, but positive TMT. So there are two issues. One, is there a role for routine stress testing in post-PCI patient? And number two, if positive, how should we proceed? As early as 2000, with BMS stent, people tried to find out whether asymptomatic ISR can be diagnosed early by stress testing. We have the EDO1, EDO2, but ultimately they found no differences in the cumulative incidences of cardiac procedures and clinical events between the two groups. Then in the DES era, early exercise TMT after PCI, there again trying to target instant restenosis. Patients underwent TMT within 3 months, classified into TMT positive and TMT negative. They looked at the MACE. TMT was positive in 17% with single vessel disease and 37% with multi-vessel disease. TMT positive patients had higher MACE in two groups of people. Number one, those with single vessel disease, and number two, if the residual syntax score was less than 8. But important to note that in those people with multi-vessel disease and residual syntax score more than 8, there was no significant correlation between positive treadmill and higher MACE. Now, how often do people do stress testing post-PCI? We have some data. Canadian patients, 112,000 patients post-PCI over a span of 24 months. More than 50% undergo stress testing, maximum between 2 and 3 months. But what is the yield? Out of the 67,000 patients who had PCI, who had stress testing, ultimately you find that only 5.9% had CAG and only 3.1% finally had PCI. So the conclusion, more than half of all patients undergo cardiac stress testing within 2 years of PCI. In fact, 1/3 undergo repeat stress testing also. But what is the yield? Only 1 in 30 tested patients underwent repeat revascularization. And even this repeat PCI, whether it does something good or bad, is open to debate. These findings reinforce the appropriate use criteria, recommendations against routine stress testing after PCI. Other population-based studies, you find 50% of the people post-PCI undergo stress testing in 6 months. 2/3 undergo a stress testing in 2 years' time. Look at the guideline, 2018 ESC guideline, asymptomatic patients. There's no class 1 recommendation, no class 2A recommendation. Only class 2B recommendation, that's a weak recommendation. Surveillance by non-invasive imaging-based stress testing, not the usual treadmill, in high-risk patient subsets. And after high-risk PCI, maybe an angiogram. And finally, maybe after 1 year following a PCI, or after 5 years following a CABG, it could be a 2B recommendation. But now we have real scientific trial data NEJM September 2022, post-PCI trial, 1,706 patients randomized after PCI, pre-discharged into two groups, 1,700 each, stress testing done after 12 months after the PCI. And look at the baseline characteristics, 21% main stem, 44% bifurcation, 15% ostial, CTO 17%, multivessel disease 69%. So real high-risk patients. 38% are diabetic, and they looked at the primary and secondary outcome at 2 years after randomization, meaning 1 year after the TMT and 2 years after the PCI. What did they find? No difference. And that is what is shown there. Primary composite outcome, total mortality, MI, hospitalization for unstable angina. Presented in ESC 2022, post-PCI trial finds no benefit to routine functional testing in high-risk PCI patients, not even ordinary patients. And disadvantages of post-PCI stress testing: financial burden, significant psychological stress, risk of ACS, which I have witnessed, false positive TMT leading to excessive invasive testing or intervention, and contrast exposure, radiation exposure. You can do a zero contrast PCI, but not a zero contrast CAG. And the illusion of wellness in the face of a somewhat unpredictable disease. You tell the patient everything is fine, your treadmill is normal, go ahead. He may die on the way, because CAD is something more than stress testing, as we saw in the CT coronary angiogram. Now, post-PCI, why TMT becomes positive? It could be due to ISR, new atherosclerosis, stent thrombosis, late and very late. Usually they are present as acute coronary syndrome. Now, residual ischemia due to incomplete revascularization, very common. A diagonal or an obtuse marginal, terminal LAD, bad disease, development of new lesion, and more important, it could be false positive. Now, having done positive TMT, what next? Details of the previous procedure and indication. The time interval between the previous PCI and TMT. That will give you an idea whether it is an ISR or not. Try to quantify the extent of positivity and ischemia. You can consider the Duke treadmill score, though it is not very reliable. And try to do imaging-based stress testing, like myocardial perfusion imaging, rather than the usual treadmill. And consider CAG if likelihood of significant ischemia. We know the sensitivity and specificity of the treadmill exercise testing is significantly less. And look at the ischemia trial. 1 year post-PCI is similar to the ischemia trial. More than half of them had severe ischemia. Still, the PCI did not really transform into significant advantage. And everything has been summarized in this expert analysis, American College of Cardiology, June 21, 2023. No value to routine functional testing above and beyond standard care in patients at high risk. And less is more. Both the ischemia and the post-PCI trials show the benefit of less is more concept. That is, if more invasive strategies of testing are performed less frequently, it will result in better patient outcome. So let me conclude. Routine post-PCI stress testing in clinically asymptomatic stable patients is not useful. Healthy lifestyle and guideline-directed therapy is more important. Treadmill exercise testing has low sensitivity and specificity. If you want to do a stress testing, it should be imaging-based, so that you get an idea about the perfusion defect in which coronary artery. Careful assessment of symptom is very important, and be aware of the asymptomatic status in a sedentary elderly person. Because if you go by symptoms, you will get into trouble. But remember, the threshold for coronary angiogram should be really low in a genuinely symptomatic patient. Do not do treadmill and all that and put the patient into problem. So whenever you think there's a genuine problem, go ahead with an angiogram and fix the issue. Thank you very much.
I think the summary slide was excellent. Almost all the points which you should remember is covered in that. Any questions from the audience? Thank you, sir.
So thank you very much.
Thank you, chairpersons and speaker. Now let's move on to the next session. And I would like to invite the chairpersons, Dr. Ashokan PK, Dr. Anil Balachandran, Dr. Praveen S, and Dr. Dinesh David onto the dais, please. Yes, sir. Let me repeat once again. The total time per speaker is 12 minutes, of which 9 minutes is for the discussion and, yeah.
12 minutes totally I will take.
Yeah, thank you.
I have to take 12 minutes. If the questions are not there, I can take 12. Can I go ahead?
I need not introduce our past president of ICC, pioneer in CTO, chairman of NIC, and chairman of IGCTO, and he is going to talk about the specific topic that is pertaining to CTO. Dr. Pratap, please.
Thank you, chairpersons. How to start an advanced CTO program, planning, technique, and equipments. Success of CTO PCI in progress CTO registry in 2016 is 81%, 21 is 88%. Out of the overall success rate, the antegrade wire escalation is 55%, retrograde is 19%, ADR is 12%. If you go antegrade and retrograde, technical success is 95% and 91% respectively. The point is, if you do only antegrade, your success is only 76%. So the retrograde approach increases the success rate in CTO PCI. But remember, CTO PCI has lower success, more complication than other complex PCI. The cost is roughly $5,000 to $7,500 more than a non-CTO PCI. So the basic problem is high cost, failure rate, complications against a CTO operator. So what is a complexity? The patients with a low ejection fraction, frail and elderly people, advanced CKD, technically ipsilateral collateral with a left dominant system, previous failed attempt, post-cabbage. Difficult lesion subsets are proximal ambiguous cap, impenetratable proximal cap, long segment CTO, calcific CTO, and ambiguous CTO course. So the JCTO score tells if the score is less than 0 or 0 to 1, the success is very high. So the complication, success, complex PCI, the point is operator experience, skills, and selection of the case are very important. So when you go to the CT angiogram in complex cases, the calcification within the occlusions, ambiguous proximal cap, and ambiguous vessel course in long occlusion can be identified. So the CT will identify calcification in more than 50%, bending in more than 45 degrees, multiple occlusion site and shrinkage. When you go to the axis, radial versus femoral, so the radial axis has lower complications, lower bleeding, improved patient comfort, but less support. So you have sheathless guides are available. Basically, with the two companies, one Asahi has a UCAT system and a Cordis has a railway access system. Radial access is actually in the progress registry is only 24% of the patients with a lower complex cases and similar technical success. Your key equipments should be ready. You should know this many guide wires, but I see that these are the guide wires commonly we have to use. The high penetration force, intermediate, and low penetration force should be available. When you go to the wire with the retrograde, these are the wires commonly used. So when you go to this case, it's a complete occluded from the angiogram occluded, where we tried everything. We went with retrograde. You look at the crux. So always the crux CTO is the toughest CTO, where we tried with a cyan black with a fine cross antegrade, Gaia 2 with a Caravel retrograde in two different planes. Cyan black changed to Gaia 3 antegrade, Gaia 2 changed to UB3 retrograde, no success. You can see my Gaia 3 is out of the vessel, totally in antegrade. I changed to UB3, no use. UB3 not progressing. Gaia 3 wire is in retrograde, you can see. So I tried, the Gaia 3 looks like in the lumen in one projection, but different projection shows totally out of the way. So we decided to take another wire. See, the antegrade wire and microcatheter in the true lumen, retrograde wire is in the false lumen. Tried 9 wires already, more than 10 gray of radiation, leave it alone, new device. We tried with a device, this wire gone down. The distally, the antegrade wire is in the true lumen, this wire. Then this is a wire called Gladius EX. It's a new wire came into the CTO segment, which is a 3-gram wire with a hydrophilic coating of 500 millimeters. Then we could not take with a balloon, no balloon crossing. We took a Nick Nano balloon. Nick Nano finally crossed. We did a lumen. We did IVUS to identify, but the vessel was totally in the lumen. We did 3 stents. Finally, we lost the PDA. How to cross the PDA? PDA UB3 tried, retrograde not crossed. Finally, we tried with antegrade. And then finally, we identified this vessel. This was the final result created in this case. This is another case, a double CTO and RCA, filled FC wire, cyan black crossed, Gayatri crossed, but the distal wire again. This actually a toughest CTO always. We see that the toughest CTOs are the tortuous calcified CTO and CTO at the crux of the RCA. Here, this wire is a new wire which is not available in India. I got a sample from a Japanese operator. This wire is actually called Miracle Neo wire, Neo 3. This is actually this wire crossed. So Miracle Neo 3 is actually a 3-gram wire with a pre-shape with a 10.5 centimeter radio opaque length. This is another wire, Conquest Pro ST, which is a sharpened tip, higher success rate in ADR, which is used for the retrograde approach. These are the 2 wires from Abbott company, Infiltrack and Infiltrack Plus, with 11-gram and 14-gram wires. You should be familiar with the microcatheters. You should be familiar with the dual lumen catheters, especially Recross and Sasuke is available now. These are the other uses in CTO. This case, if you look at, there is a CTO segment actually at the circumflex, the wire, no wire is going. We tried with this one. You can see that this wire will take a 90-degree angle on the other side. First wire crosses. Then the second wire crosses, which is actually called Recross. Recross is actually a device which is having 2 OTW lumen and 3 exit port, and which is actually taken. It can exchange both wires, helps in device-based ADR, helps in parallel wiring. This is a new device came into the picture. You should know about the low-profile balloons, low-profile balloon for the CTO crossing, and the guide extension catheters. It can increase the backup to bypass the calcification and tortuosity. It helps in reverse cut. You should have an IVUS utility in all CTO segments. Which are the IVUS available? Philips and Thermo. Philips is available here, but we use mainly Boston Scientific. The ideal one is a Thermo IVUS, which is anti-owl or a Navi focus, which is only 2.5 French, and there is a megahertz of this thing. And IVUS can be done for associated with it. Then comes the laser. Laser is with a higher technical one. It can be balloon uncrossable lesion you can use, and balloon undilatable lesion, and ISR CTOs. When you go to the ambiguous proximal cap, you have an IVUS guided approach, in IVUS guided entry or retrograde as the marker. These are the situations which we can use an ambiguous cap. When you go to the ambiguous CTO course, retrograde wire as the marker and base technique can be used. In the case the move cap, where there is no appropriately sized side branch for IVUS, you can use this one. When you have a CTO with this one, impenetrable proximal cap, you have no other way out where you can increase the support, increase the penetrating power. Increase the support with the microcatheters, guide extensions and wires. And where you cannot penetrate, bypass the graft. You can have scratch and go technique, base, Carlino, and subintimal track. In a calcified CTO, difficulty in CTO crossing, device uncrossability, undilatable lesions. If you have this problem, you have a lot of materials available. I cannot go because the time is not. Undilatable lesion, again, the same thing can be used. ISR CTO is a difficult re-entry. The point is antegrade approach is to be done and a crossbars can be used. ISR CTO is 15% of the CTOs available. When you come to the lastly, the mechanical circulator support, only 4.5% of the cases it is used. prophylactically, and it is type 2B, class 2B recommendation is there. So if you have an appropriate, proper technique, adequate hardwire, skilled operator, success in CTO PCI can be more than 90%. Thank you.
Thank you, Dr. Pratap. This topic is open for discussion. 1 or 2 questions is allowed. Dr. Praveen, what's your?
No, sir. With your vast experience in CTO area, what is your comment on attempting PCI in CTO PCS in non-surgical centers where you don't have a surgical backup? What is your take on that?
I do CTOs in most of the non-surgical setup. Actually, the data is telling that if you're skilled, you should know when to stop it. That's the most important thing in CTO. If you know when to stop it, if the radiation dose is very high, the contrast dose is very high, and if you cannot attempt not to create any complication, that is all. If you create a complication in a CTO, definitely the mortality is higher, but I'm telling that you should know when to stop it. Surgeons also cannot help you in most of the time. People are thinking that surgical backup can help anything. I don't think surgeon can help you anyway.
Dr. Pratap, now the CTO, the procedure rate is coming down. What's your opinion? Whether it's because the cases are coming down or the operators are not interested?
No, basically earlier the people were treating only on medical management. Then CTO numbers were very high. When the acute MI centers gone up very high, then naturally the CTO numbers should come down. That is the major reason, number one. That is the major reason that CTO numbers are coming down. Not because the CTOs are less. CTOs are there. All the CTOs are coming also.
That means you are getting more complex CTOs nowadays.
More complex CTOs, definitely more ISR CTOs, more post-CABG CTOs.
Any other questions? Otherwise, I would like to know one secret. A mic, please. Please, use the mic. To sir.
So complication is actually...
Have you had any coronary aneurysms and infected stents? Because CTOs are the highest incidence of these. That's what we listened in the morning talk.
No. That is actually occasional incident. I have seen some of the cases of coronary infected aneurysms are all non-CTO segments. It is not that is true. But he is telling that if you use more time, you will get infection chances very high. Infection is not because of that. Mainly the complications are, one is perforation, second is death, contrast-induced nephropathy, radiation dose. These are the major complications.
So, thank you, Dr. Pratap, for the excellent talk.
Next talk is by Dr. Shafiq Matamal. He's going to talk on how will I image and plan TAVR.
Warm morning to all. First of all, I would like to thank the organizers for this wonderful program. I feel a lot of warmth here. So everything in TAVR, planning of TAVR starts with a CECT after you diagnose severe aortic stenosis in the echo lab. So a perfectly done CT helps in integration of imaging into patient selection, treatment planning, device selection, and device positioning. So basically, historically, the CT was initially designed to define peripheral vessels, but then the applicability was extended to the annular sizing and then further planning, and there was more refinement over the years. So currently, it is considered as the gold standard tool for annular sizing, determination of risk of coronary injury or coronary occlusion, annular injury or coronary occlusion, and to provide specific information of coplanar and cusp overlap angles so that you can do more refined procedure to have more long-term, favorable long-term outcome. So typically, all these CT scanner machines have their own protocols how to acquire. Basically, it's a ECG synchronized collection of CT data, and you use nearly 100 ml of contrast injected through antecubital vein. And sometimes if there is a contraindication for, if there is an uncertainty in AS severity in echo, CT calcium score sometimes helps to define severity. If a score of more than 3,000 in men and more than 1,600 in female defines that severe aortic stenosis is more likely. So what are the things that we do in CT? One, first thing that we look up is to define the image quality. If you have sharp annular contour margins defined by the CT, then you know that this is the image quality is good and dependable. Then annulus, which is the most important part of valve sizing. Landing zone calcification, root measurements, then SOV and coronary heights and the STJ junction analysis, then fluoroscopy planning, define the angles, look at the horizontality. So all these helps to define what are the troubleshooting that you can have during the device deployment. Then define the vascular access, size, tortuosity, calcification, and whether or not you need intervention before TAVR. And then other addition, then coronary artery disease, the layout, the height, and possible complication that can happen can be predicted during CT. And then other information, non-cardiac, non-vascular with the CT. So most important measured is the annulus measurement. In CT, it is defined as a luminal contour with a virtual plane aligned with the most basal attachment points of 3 aortic valgus, what is called as basal hinge points. So it is typically measured in systole because it's less elliptical, and there are methods to do manually is possible in practically any CT software, and but more often we use Trimensio, which is now standardized. The measurement, you click the automatic and the software finds a okay, the software points the center marker here, and then we can, once we make 3 dots, it just gives the information of annulus, and then you can make measurements, and you get the perimeter and area derived diameter of annulus. So most of the valves come with a predetermined sizing chart according to the annulus determined by this CT. The next is landing zone calcium, where we define actually where exactly is the calcium below and what is the diameter and anatomy of the landing zone. So it is typically measured around 3 millimeter below the lowest portion of the annulus line. You can see that. And once we define and see this area, then you take a measurements here, and then you can see if there is any calcium which is protruding into the lumen. All these actually predict different types of complications. So annular rupture is one dreaded complication of TAVR which can be predicted by CT. If there is a subannular calcification, especially if it is nodular and protruding into the left ventricular outflow tract, there is high risk of annular rupture. So you have to avoid oversizing of TAVR prosthesis in such patients. AV block, yes, if there is reduced implant depth, then it is now shown that it reduces the incidence of complete heart block and mortality. So how do you know that? If there is you can measure a membranous septal length in the CT, and if it is shorter, it is likely to have more risk of complete heart block after valve deployment. This is the way you can measure it. Actually, you can see the point where exactly the muscular septum ends here, and this is the membranous septal that is seen, and you take the measurement. If it is short, it is highly likely that this patient may have more incidence of a complete heart block during valve deployment. You can adjust your deployment height according to that. Aortic root measurements and coronary height, which gives an idea about how the leaflet, when you deploy the device, is going to go, and what is the relationship of the leaflet tip with the left and right coronary artery. Here you can see, you measure the left coronary, you take this point and then measure starting from here till the lower part of the left coronary artery. Similarly, you do it on the right side, and you can see here, once the right coronary artery comes in, and you can have measurements starting from here till the lower part of the right coronary artery. So both these helps to plan additional protective coronary measures if necessary. Then measurement of angle, and here you can actually, Trimencio has a C-arm mode. You can keep the camera and find out the angle where actually all the 3 dots come in one line. That's a coplanar view. And if you need to have a cusp overlap view, you can see these 2 dots merged and left-right cusp overlap view. And so all these angles can be deduced with the CT. This is the new methods. Cusp overlap method is to reduce the depth of deployment so that the incidence of complete heart block can be reduced. And finally, the access vessel. So you can actually see precisely the entire diameter, the puncture point, the tortuosity, the level of calcium, and whether or not you need to do intervention in the iliac vessel before CT. And with the invent of IVL in calcific vessels, now the transfemoral percentage of transfemoral access for TAVR is increasing ever. So finally, we get a report with a comprehensive data on valve morphology, whether it is tricuspid or a bicuspid, the distribution of calcium, whether it is symmetric or eccentric. Then you get the annular dimensions, then area or perimeter, and depending upon the valve platform that you select, and then you got all the diameters in the STJ. And all these actually help to define the valve size, the balloon dilatation size, the post-dilatation balloon size, whether or not you need to protect the coronary by left main and right coronary artery heights, and the coplanar projections, angular projections to see how your landing of valve has to be deployed. And the iliac vessels, how smooth your entry and exit with the device will be, and additional information if you use other access. And a couple of words about bicuspid. The calcified raphe and excessive leaflet calcification are 2 things that you learn on CT, which will define the risk as well as less success of bicuspid. And you try to define what is the aorto annular complex shape, and then helps the sizing in bicuspid. The general principle in bicuspid valve sizing is size it less so that to avoid complication. Final word about zero contrast TAVI. You can do TAVI if there is a risk of CKD. So you do non-contrast CT or MRI and see the calcium and make measurement, and with the help of 3D TEE, we can do the sizing, and there are methods to get the procedure safer. To summarize, from TAVI has grown with the help of this planning from fairly morbid procedure to very simple, almost a daycare procedure over these years. So CT has an imaging, as a crucial role in planning TAVR. It helps in device sizing, vascular access management, and in the near future we are getting multimodality imaging. We can have fusion of the CT finding in the fluoroscopy. All helps to reduce the dose of contrast volume, the radiation dose, and better accuracy and safety. Thank you so much for your patient listening.
Thank you. Yeah, mentioned everything about the role of CT scan as important non-invasive modality in planning of the TAVR procedures. In your experience, what do you think, what is the change in the CT data's pre-procedure in the past versus the recent? Is there any change in assessment, pre-procedure assessment based on CT?
Yes, as I mentioned in one of the slides, that the complications, prediction of complications and avoidance has improved, and there is a lot of learning how to reduce these complete heart block. With respect to CT defining of this cusp overlap angles. So when you get the left-right cusp overlap technique, so you can precisely define the landing zone of a self-expanding and balloon expandable valve. And when the height is reduced, here you see the valve position during deployment with respect to the non-coronary cusp, which is closer to the conduction system. That is the best example where CT actually has helped to reduce long-term complications.
So CT features which suggest that you will go for a balloon expandable rather than a self-expanding valve.
Again, if there is a nodular calcium, in the leaflet, asymmetrical calcium, then the chance of paravalvular leak is high. In such scenarios, devices specially designed to reduce the paravalvular with the extra cuff, like a balloon expandable valve with a new generation balloon expandable valve, do well if they are safe. In the same way, if it is a bicuspid, if it is a small annulus, in such scenarios, rather than an intra-annular platform, we need a supra-annular device. So in such cases, we can prefer a self-expanding platform. So it helps.
Dr. Magesh.
Yeah, that is a superb talk. I mean, you really covered all the material in one go. Just want to know, CT coronary angiogram, is it done as a part of a TAVR protocol regularly? Or do you ask for it separately? And then do you do it in all the cases?
Actually, when and how to tackle the coronaries with respect to TAVR is a big controversy. Now we are having data saying that you just don't do coronary angiogram and think about revascularization. Do the TAVR and then do symptom-guided coronary revascularization. And about the CT coronary angiogram, they have slightly different protocol, but there are radiology papers where they have integrated in one shot, where they did the CT angio also. So that again helps to define the outcome risk. Because if there is a left main or osteoproximal right coronary artery disease, then you need to tackle. Otherwise, you can safely go ahead with TAVR first and coronary only if there is. Nodular calcium is known to reduce the success of TAVR in two ways. One is it produces paravalvular leak. Second one, it predisposes for annular rupture when there is excessive pressure applied. But embolizing is very rare because if it embolizes, it's going to be really dangerous.
So thank you, Dr. Shafiq,
Thank
for
you.
the excellent talk. We'll move on to the next session.
Check. Yeah. Thank you, chairpersons and speaker. Now moving on to the session 5, I would like to invite the chairpersons, Dr. Placid Sebastian, Dr. Shafiq Mattumal, Dr. Ravindran P. and Dr. Jyoti Vijay onto the dais, please.
Good morning to you all. Now we'll move on to the next topic, that is the procedural tips and tricks achieving the optimal results in TAVR by Dr. Anantharaman. We all know that he's a famous interventional cardiologist from Chennai, has vast experience in structural heart disease, and he has a large number of TAVR procedures done by him. Over to you, sir.
Thank you. Good morning to all, and sincere thanks to Dr. Arshad and all the organizers for this opportunity, and the Indian College of Cardiology Kerala chapter. I'll just take you through a few slides on the important tips and tricks to get the TAVR successful, because it's more than 20 years kind of a mature procedure now. So this was in 2007, we were treating very frail kind of surgical reject patients. By 23, we treat more than kind of all AS comers, low risk, moderate risk, high risk, everything. So what is important is we need to get excellent outcomes. It's very important that we get minimal vascular complications, minimal kind of all the other kind of cost issues, as well as surgical-like results. because now we are dealing with younger patients and lower risk patients. So very careful planning is important. Obviously, the previous talk by my colleague Shafiq has clearly shown how important CT is in terms of planning. And I will show you in the next few slides, once your CT is done, what are all the important aspects you need to look at. Because around 90% of the procedure is done outside the lab. TAVI, 90% is done outside the lab. That means when you do the assessment. And only 10% you are going to go to the lab and just undertake what you have assessed. Unlike the skill set you needed to do the CTO cases and other things like Dr. Pratap showed, here the skill set is not that much, but the assessment is very, very important. So you need a good pre-procedural planning, as Sushil says, understanding the devices, procedural technique, and you need some luck in some cases. So assessment, obviously, it was in detail dealt by my colleague in the previous talk. You will get tortuosities. Tortuosities is not an issue. If it is only tortuous, as soon as you put a stiff wire like a Lunderquist, it will straighten out. The issue is tortuous with calcification and with the smaller size. So if you have tortuous, calcium, and smaller size, that's a problem. Because the vessel which is calcified, it will not stretch. So vessels like this, even if it's tortuous, if you put two set of stiff wires, it will straighten out. But vessels like this, don't push too hard. You have to change the wire. So if that was a Confida or a Safari, you change to Lunderquist. And if needed, if the vessel accepts, you put a sheath. Otherwise, go for alternate access. So it's very important to assess the access properly and respect it. And if there is any issues, go for alternate access. Now, the next important tip is about the sheath size. All companies claim, especially the self-expanding claim, it's 14 French, balloon expanding claim, it is 16 French, 18 French. Don't trust any of them. What you see, the inner diameter and the outer diameter. The outer diameter is very important because that is what causes a 1:1 sort of vessel injury, not the inner diameter. What the companies claim is this unexpanded diameter. So if the Edwards or my valve says 6.7, actually when the valve goes in transiently, you need an 8 millimeter vessel. So it's very important with the balloon expandable valve. So a transient set of expansion, more than 8 millimeters needed, otherwise you will cause vessel injury. With a self-expanding valve, if it is 6 millimeter, it is 6 millimeter, unless you are going to use a sheath. So if you're using inline sheath that comes with the valve, then this diameter is fine. If you're using an extra sheath, then you need to have that extra sort of size in the vessel size. Because major vascular injuries comes when you cross that 1:1, vessel size to the sheath size. Your sort of risk of injuries. So please remember that. Otherwise, we had these issues in the past when the TAVR came in 2012, when it was 24 French, all these things. Nowadays, we don't have this. The next sort of tip is the complex aortic anatomies. Sometimes you have tortuosity, sometimes you have aneurysms, sometimes you have all the other issues. This was a case done by myself and by my colleague, first in man sort of proof of feasibility case in the world on a PCI, TAVR, and TEVAR as a transcaval approach because none of the femoral approaches were acceptable. But I don't think we need to do this anymore. This is a time when IVL was not available. Nowadays, you can optimize it with IVL and you can get a good result. Even expand it enough to get a TEVAR as well. The next is the aortic anatomy. So the aortic valve anatomy, you have the virtual annulus. That's the nadir point of all three cusps. And then you have the coronaries, you have the sinuses, STJ height, LVOT. All parameters are important. As it was shown in the previous talk, you need to take into account all parameters. And you go through that in detail. When you look at the annulus, for the self-expanding valve, the perimeter is important because the self-expanding valve will conform to the shape of the annulus. So you take the perimeter. But the balloon expandable will not conform, it will expand circular. So you need to take into account the area. So when you're sizing for a balloon expandable, it is area-based, self-expandable, it is perimeter-based. As shown here, the coronary height, the sinus width. So if you have a low coronary height and a narrow sinus, that patient has a coronary obstruction risk. So please take all parameters into account. The other thing is improper assessment. Here the valve leaflet is still seen. If you still see the valve, assessing the annulus at that point will give you a very false perimeter or area assessment. and you will have complications. CT is important. If your CT scanner is not more than 128, if you're like 64 slice, it will be taken in sort of series and each volume will be added. So you will get this stepwise artifact. When you get this stepwise artifact, your assessment is no good. So please make sure that you don't get this stepwise artifact, you don't get this breadth artifact. It's very important to get a proper CT before you analyze it. Implantation techniques, obviously, as shown in this case, the annular calcium is important. If you don't respect that, if you oversize it, you will get hematoma and a rupture. That was shown in the previous assessment by my colleague as well. Now the techniques, the coplanar view, what is the coplanar view? Obviously, you get all three cusps in sort of nice straight line. If you don't get it, you will get parallax. I will show you in the next slide. So what you want is a nice coplanar, a straight line annulus, and your valve perpendicular to that. But majority of the time it will not happen. If it happens, you are very lucky. You get a nice annulus, you get a nice valve, no parallax. This case will go well. You will get a beautiful height on both sides, depth and valve implant. But most of the time you will get something like this. If you remove the parallax of the valve, it will not be in central. If you have parallax, it will look central. So it's very important that you remove the parallax, but understand how the valve is going to be deployed. If you have parallax, it will deploy like this oval. So valve parallax you need to remove. If you remove the valve parallax, the depth assessment will be fine, both sides. Otherwise, the depth assessment will not be good. Balloon expandable, when you deploy, you need to understand the top line will stay as it is. The bottom line will move upward because the valve will foreshorten from LV to the aorta. So when you are placing, the central marker is placed in the annulus, it will foreshorten from the LV to aorta. So please do remember that. Wire position, we used to be very much concentrating too much on this when we were pre-shaping on our own, when you were pre-shaping the amplets. Nowadays, you get pre-shaped wire, Confida wire, Safari, as well as pre-shaped Lundaquist double. Nowadays, you don't need to pay too much, but you still need to pay attention that it is in contact, there is no sort of sharp edges, and because that sharp edge is what will cause the LV perforation. TE, obviously TE is important. Most of us are moving towards conscious sedation, but still these beginning centers are less than sort of 20 numbers in a year. Please do use TE, because as soon as a patient has hypotension, you will know what exactly is happening. Otherwise, you will not know whether it's a perforation, whether it's a mitral regurg, or whether it's a paravalvular leak, what has happened. So please do it with TE in the initial stages. Coronaries, as we have discussed before, if the patient is unstable, acute coronary, LV dysfunction, those cases revascularize. All the other cases, you can do it later. After the procedure, it's very important to take completion angiogram. Don't be carried away by the sort of European or US proctors coming in, and when you go and observe cases, some of them, they don't do completion angiograms. Don't do that. Because completion angiogram is very important. It will tell you if there is an issue on the table, like this one dissection, you can balloon it and settle it down, or perforations. Now, for our practice, where the numbers are less, please do concentrate. Devices, you have a self-expanding device, you will have a balloon expanding device which can bend. Device choice based on small annulus, you take a self-expanding. Heavy calcium, you take a self-expanding. Low coronary height, you take a balloon expanding. And valve in valves, apart from aortic, all the others will be balloon expanding. So in terms of assessment, as I showed the top 10 tips, I'll show some case examples quickly. This is a small annulus case, 75-year-old, very small annulus, 19 millimeters, and you do get fantastic result. When you assess patients for TAVI, please do remember patient's body surface area and what is the potential patient processes mismatch you are going to give for that patient using a self or a balloon expanding valve. I'll skip that. I'll show the final result. So that's a self-expanding valve, 23 evolute. So even for that small annulus, when you use a 23 evolute, the gradient you can see, the mean gradient is 5. So you get a fantastic result. Now challenges is bicuspid. When you go for proctoring, I see more than 50% of the cases in India is bicuspid, irrespective of the age, whether it's 30, whether it's 40, whether it's 70, whether it's 80. We see quite a lot of bicuspids. The bicuspids comes with its own problem. So they have horizontal aorta, they have calcification in places where you don't want, especially this raphe calcification, it will give trouble. So this is one case where the right non is fused. When you get a right and non-fused, the orifice is such that it will be very difficult to take the self-expanding valve. As shown in the picture, you cross it and the valve will come and go up. So it's very difficult to cross. You can see how the valve is coming down, hitting the this cusp, and then it has to go up. Majority of the time it's difficult, so you have to assist it. The last picture shows it's a snare, it's centralizing it. You assist it. Once you assist and centralize it, you will get a good result. So these are the techniques you can use for these cases. Balloon supported, buddy wire supported, snare assisted, all different techniques. All these cases can be done. Calcified annulus, I think we were having questions about the nodular calcium, the self-expanding valve will fit well. This particular case should not be done. The STJ is less than sort of 9 to 10. If you put a valve, you will get a gradient. So for the purpose of time, I'll skip it. All those cases were done. Now emergency cases, double valve failures, you can do it. You can do a valve-in-valve aortic, valve-in-valve mitral, and a pacemaker. All this is possible in 2023, cost is the issue. To summarize, obviously from 2017 to 2023, the cases can be done. The procedural planning is important, and patients' sort of devices and operator experience is important. Thank you.
Excellent talk. As the TAVR becomes more and more popular, the whole aim actually is to foresee all the complication. As he rightly said, 90% can be done from the planning itself. And can you elaborate what's your experience in those complications and how did you tackle in the initial phase of your career?
Yeah, I think the last few slides I skipped very rapidly because when you have tortuous vessels, you start with your assessment. When you have tortuous vessels, if there is no calcium, then straight wire will sort of open it up or straighten it out. When you have tortuous aorta, you put a second straight wire in your pigtail, contralateral pigtail, that will take it through. Because sometimes you get this pseudocoarctation, bicuspid valves, pseudocoarctation, much tortuosity. So apart from your stiff wire in the main axis, the second axis where you put a Landequist wire, that will straighten it out. In terms of the horizontal aorta, the next generation self-expanding, the FX is coming in 2-3 months' time, then you don't need to worry. It will flex nicely, it will go through. Currently, you have to assist with snare or balloon. Otherwise, you have to use the balloon expandable valve. The most important is the annular calcium. So when you have annular calcium, please pay attention. Bicuspids with annular calcium, they are the worst. If the patient is suitable for surgery, send for surgery. So you have to categorize as surgery favor, TAVR favor. If the patient is suitable for surgery, send for surgery. If it's not, if you're going to take for TAVI, self-expanding with adequate pre-dilatation, it will oppose well. If you're going to use a balloon expandable, be cautious, undersize it, almost 0 to 5%. And during the time of deployment, watch, have a transcatheter watch. And if you think the calcium is going towards the annulars, going to cause some injury, stop there. Around 80%, 90% deployment, stop there. Because you'll get opposition, you won't get gradient. Too much pushing will cause annulus rupture. All these things we can predict it during CT planning. And you have to go with an idea about what the case is. Each case is different, what you're going to expect, and be prepared to have the bailout kit ready, including ECMO. If there is a potential annular rupture risk, have the ECMO ready because that will save the day.
Thank you, Dr. Indraman. Excellent presentation. I have one question. What is the current guideline regarding the age cutoff for the TAVR procedure? Now, initially we started, it was 75, now it's coming down. So what is in your clinical practice, what's the guideline says about it?
The two important aspects we need to remember, low risk and age. We should not get confused between the low risk and younger age or a high risk and an elderly age. All the trials, low risk trials, the mean age was 78, 79. The low risk core valve trial, the low risk balloon expandable trial, the mean age was 78, 79. So the low risk doesn't mean young age. So the current guidelines cutoff is 65 in Europe and US. The current cutoff we take in India is around 60. So if the patient is 60 and above, and if all the other things are suitable for a TAVI, consider for a TAVR. If it's a patient is bicuspid, calcified type 1 Raphe, where surgery is favorable, then send for surgery. So you have to categorize as surgery favorable, TAVR favorable. At the moment, the cutoff is 60 to 65 for TAVR. Yeah, that's a good question. At the moment, the international follow-up we have is around almost 7 to 8 years, or around 10 years now coming to the core valve. The local follow-up, what I have is 2015 was the first case I did here, so it's about 7 years follow-up. The increasing gradient, you will get it with the balloon expandable if you put it in a small valve. Or when you started with the LV dysfunction, even with self-expanding, the gradient on the table is good. Subsequently, you might see a slight increase in gradient. In those cases, you can do a balloon fracture of the valve if you put in a valve in valve, even at a later stage. I've done a balloon fracture after 1 year as the gradient has gone up. That was a valve in valve for a surgical valve. So you can do a delayed balloon fracture as well.
I think this time is over. Thank you, Dr. Anantharaman, for the excellent talk.
Yeah, thank you everyone. Now I request Dr. Anantharaman to stay back onto the stage, please. And I request Dr. Placid Sebastian to present a memento to Dr. Anantharaman as a token of love on behalf of ICC Kerala chapter. Yes. And we may witness this auspicious moment with a big round of applause, please, everyone. Thank you. Now we will move on to the next session, and I request the chairpersons on the dais, Dr. R. Anantharaman, Dr. Josie Chaku, Dr. Thomas Matthew, and Dr. Mohammed Isa.
Good morning to all. Without further ado, I invite Dr. Rajiv to give a presentation on 3D echocardiography basics.
Thank you. So 3D echocardiography basics. So as you all know, 2D image represents a tomographic cut of a region of interest through one of the three planes, either frontal, vertical, or transverse. Whereas 3D image encompasses the entire region of interest in a pyramidal volume. Now, with phenomenal advancements in the current matrix array transducers, now it's possible to have incremental increase in imaging frame rates, then have real-time 3D imaging into 3D transducers, PE transducers. And what are the acquisition modes? Different platforms have different names. This is what I'm using GE, so I use something, the smallest is called a bird's view, where you have a 60-degree azimuthal plane, on that means a lateral, then 15-degree depth, which has a high frame rate of more than 65, whereas you have a large pyramidal set where you have a 60 and 60. That means 60 lateral and 60 anteroposteriorly. So that is the pyramidal volume you get with a 4D large. That is probably the most commonly used thing. So it's a single beat 4D large volume acquisition. Then if you want, say, for example, you have to analyze a mitral valve or aortic valve, you can have a 4D zoom where you can truncated 3D pyramids can be done in that large 3D volume. And 4D strain needs a high frame rate, and progressive decrease in 3D volume or frame rate as 3D volumetric data gets larger. So the larger the volume, the frame rate will be smaller. And size can be made smaller using the lateral size width and the elevation depth, that is anteroposteriorly. So single beat versus multi-beat. Earlier it was all multi-beat. Now with the current advancements, single beat acquisition is possible. But if you have a large thing, large volume, multi-beat will give high frame rates, but there can be a lot of artifacts like stitch artifacts. And the multi-beat acquisition with 3D, with ECG gating and 3D color can be done. So what you have to do is first obtain the highest 2D quality Then press the Decide 3D button, optimize 3D image, larger 3D volumetric data, the lower the frame rate or volume rate. And optimize the compression settings to have a good image. Then use tissue cropping. I will show some examples. And mitral valve volumetric data set, it says single beat or real time. We can achieve rates of frame rates of about 20 to 24. For end-fast mitral valve view, you have to rotate the picture so that the aorta comes at the top at 12 o'clock. So multi-beat has a better frame rate, but a lot of stitch artifacts can happen. There's a respiratory artifacts. If the probe moves, that also can cause a problem. So this is a large volume acquisition. So 60 into 60. If you want, you can go to measure, then volume, and 4D auto LV quantification. So go to end-diastolic volume, then auto. So this is the end-diastolic volume. Then you go to end-systolic volume. So you get end-diastolic volume, ESV, ejection fraction, everything. And then you can have volume waveform, and you can have LV mass assessment, then 4D strain, so you can have longitudinal strain, area strain, circumferential strain, torsion, everything can be obtained from this. And all this region of interest you can modify, you can bring it into the frame. Then you can have if you want to measure the LA volume and LA strain, you can do that. Go to measure, volume, LA quantification. Then you can take it mitral valve center, then review. So you get the LA volume and LA strain. And if you get the results, so this is the LA strain. You have, if you look here, you can see the LA reservoir strain, LA conduit strain, and contractile strain. LA reservoir strain is positive, other two strains are negative. So this is LA volume and LA strain. Then I will show something else. I'll show an ASD. So we can bring the translation here. You can then stop and select the frame. And again, you can make measurements here. Then I go to 20. So if you go, this is a mitral valve, if you want to go to mitral valve, you can make measurements of the mitral valve. At valve quantification, to align views, then set landmarks, meta-analysis here, another one here, then another in here, then another one here. This is a cooptation point, and that. So this is what you get, and you can see the results. So all the tending height, everything can be seen here. All the measurements of the analysts. Now I'll show something else, 42. This is the aortic valve measure. This is called multiplanar reconstruction. Align views. So LVOT segmentation. So this will give all the values. Aortic annulus you can measure here. This is the aortic annulus. Aortic annulus you can measure. Then all these maximum diameter, minimum diameter, everything can be obtained. This. Then I will show. And this is something called a plexi light, where you can see an LA appendage clot. You can put lights into the LA appendage and see it very well. Then MS and MR. This last one. This 3D assessment of the MR volume, 34. This 3D volume, so you can rotate and see and assess it better. You can, in fact, cut through, if you multiplan reconstruction, you can cut through the regurgitant orifice and then make measurements. Because of lack of time, I can show much more. There are a lot of things which I can show. Thank you.
That's fantastic, Dr. Raju. Obviously, the 3D has come up a long way, especially for structural interventions. Now, it's more of the echo person is the important person in the cath lab. As we are moving towards the mitra clip, tri-clip, all the other structural interventions, the interventionalist is more like a technician. They just move this side, that side. But the main person is the echo person who guides.
For mitra clip.
Yeah, and all the other future interventions. So I think we need to have a generation of cardiologists, next generation, who are imaging interventional cardiologists. So where they are well versed with CT, MRI, as well as good transesophageal echo. I think one of the images you showed is the aortic annulus assessment with the MPR. So for patients who are coming as emergency, where you cannot do a CT scan, that multiplanar reconstruction with moving up and down and getting the annulus, it's almost as good as a CT scan. And we have seen it, and it works well.
Any comments or questions from the panel?
What I have seen is that for LV volumetric analysis and all, obtaining a good 2D images is very important.
Yes.
Otherwise, we will get very erroneous values when you go
Everything
to
a good
3D calculation.
3D should have a basic good 2D. But T is excellent. I forgot to tell one thing, because for the mitral valve NFAS assessment, you have to align the aorta at the 12 o'clock position so that the orient is correct. You are looking from the LA, it is the aorta at the top, and on the left hand side is the LA appendage. Then you can see the anterolateral commissure, and near the LA appendage and posterolateral commissure. You can beautifully see all this.
Thank you.
Hi, so yeah.
We'll go to the next talk.
Thank you.
Thank you, Dr. Rajiv. Next talk is on percutaneous mitral replacement. As you know, it's more and more of a degenerative mitral disease nowadays. And these patients often have high surgical risk due to the other comorbidities. And percutaneous surgical mitral replacement is a good option for them. And we have Dr. Ashraf, Professor of Cardiology, Periyar Medical College. Dr. Ashraf, please.
Respected Chairperson, especially the structural expert, Dr. Anantharaman, and my dear colleagues, and also the junior and senior colleagues. First of all, thank you, ICC Scientific Committee, for giving me this opportunity. The transcutaneous mitral valve replacement is an emerging area. Previously, it is an area of the surgeons. So, just a background, the clinical risk profile and the anatomical consideration, they influence the mitral intervention technique selection. You have the primary and secondary, and majority of currently available therapy indicated by the guidelines is by surgical repair or replacement. And in certain scenarios, especially mitral valve prolapse, you have a mitral clip, and very prohibitive risk or very high surgical risk, there is a role for the TMVR. So the procedure goals and challenges of TMVR, the design and procedures, like you had to completely eliminate the MR and less recurrence of MR. So initially it was the surgical MVR, now the transition to TMVR in selected cases. But there are certain challenges and ineligibility. The reasons for the screening failure, majority is related to the LVOT. And the small LVOT or LVOT area is the size, the diameter less than 1.7 or 1.9 centimeter square, or the small annulus and the MAC with the different calcification, there are issues, and small LV, LA thrombus, all these are issues. So the limited applicability of the current TMVR designed to real world anatomy, why there is a high rejection rate? Because unlike a TAVR, the development of universal device tool, the one designed first fit all, may be challenging, and there are architectural changes occurring around the annulus in MR patient, because unlike the aortic annulus, it is static, whereas mitral annulus is dynamic and different shape and not in the one plane. So the initial studies, the pivotal trials are with the transapical route, but now we have the trials with the transeptal, the SAPIEN 3 and HighLife and Interpret, and there are data on that. So the transition to transeptal delivery may not be smooth, and there are technical challenges, and like crossing profile, especially across the IAS, and valve fatigue issues by going smaller, and navigatability and coaxiality challenges. The transition to TS delivery with clinically available TMVR device will require important engineering modification, size, possibility, valve design, and anchoring mechanism. So the future of the TMVR field, the adapt design to fit multiple anatomical variation, real world anatomy, especially elderly MAC patients, and also larger size packed in small catheters, and evolution of imaging, planning, and guidance. So here comes the previous speaker said the imaging has very crucial role. And the classical example is mitral valve in valve, the bioprosthetic valve. The procedure planning, you had to identify the true internal diameter, decide the size of the TH. So each product has different sizing parameters, and the fluoroscopic appearance of these valves decides ideal position of the THV during the neo-annulus. And this, you had to know about the type and sizes. So the procedure identify the bioprocess, the type and size, and you had to go through the operating notes and the bioprocess manufacture and through and identification with the fluoroscopic appearance. and you had to take different RILO and different, and you had to superimpose the CT image also. So true ID is mechanical internal diameter after the leaflet mounting on the stent frame, a label size and external stent diameter. So you have a lot of information found in the even mitral VIV app is available, and you can go through that and you can take the size and so the operative technique, the procedure planning, always in the general anesthesia and the narrowest diameter, the new annulus of the bioprosthetic valve, and use fluoroscopic landmark to identify the new annulus, and for securing the new valves, that is percutance valve device positioning and familiar with the relative position of the stent frame and information available on the app. So there is markers on that EPIC, and EPIC they usually performed in Kerala. I think the majority of bioprosthetic valve in the mitral and the BioCore, that area, the marker, the arrow pointing that area, each has different level. For example, Magna is different and BioCore is different. So you should know the markers. Now the selection. The most common device uses balloon expanded Sapien. There are a lot of studies on that, and MyVal is almost like Sapien, and limited experience with the mechanical expand like Lotus, and now the MyVal is available in Indian market. And based on the user performance, experience, and access route, you have initially it was all over the world with the transapical and transat. Very, very rarely the selected cases the transat in experience hand, and sizing algorithm. Each device has oversize according. For example, you have mitral annular distance is almost 32 millimeter, median to lateral, and the area is more than 600. Probably Sapien or MyVal will be around 29 mm device. So each has different sizing according to the diameter, according to the area, and also angle with the LVOT, the mitral annulus. So now comes the operative technique in the valve ring procedure. Previously ring and in calcification and degeneration MR, how to proceed. So there are a lot of ring classification like complete, near complete and incomplete, and there is rigid and semi-rigid and flexible. So important for ring properties, ring circularity, the anchoring, and ring size and dimension and radiopacity. As a interventional cardiologist, you have to habit of at least visiting one cardiothoracic department and surgical team, how they are implanted. So we'll come to know how the angle, how the internal, real anatomy of the mitral valve, then it will be easy for you and for the future structural intervention. The operative technique, the procedure planning again in the ring part, the Sorin, Memo 3D, the Sorin was previously, lot of patients underwent that Sorin rings in especially North India. Now Sorin is coming again in India for the bigger market. That anchoring and circularity is very good for the TMVR technique. And others like incomplete band and corkscrew band is all very difficult. So this is very, very important, the LVOT obstruction. That is most important. People are asking when you send for the CT, they will specifically look at the LVOT obstruction. So they will superimpose that our echo and CT image with the device and see how it is, how much obstruction is there. So there is if there is deeper placement of the LV of the processes, there is a chance of LVOT obstruction and flaring and MA ankle and the septal bulge. If the anterior mitral leaflet is longer, there is high chance. So there are techniques for that. Newer techniques, the risk of LVOT is high. For example, you can do the alcohol septal ablation pre or post procedure. The lampoon is a separate electrocauterization of the midline of the anterior mitral left and tearing it, and you can reduce the LVOT obstruction after the procedure. And many of the time it is 80:20 location of the valve, and because there will be always there is high pressure across the mitral valve, so it can embolize to left atrium. So majority will be the 80% the LV and 20, and it varies depends on the processes. So the complications is embolization. High closing pressures on the mitral valve create the unique problem and avoid parallel deployment and correctly oversize using the true ID. So here because the closing pressure is compared to aortic valve is very, very high, and parallel deployment risk of embolization high when compared to the conical deployment. So this is one example BioCore, just show that 3-month show bioprosthetic MVR and mitral valve annulus with LVOTs. You can see the severe MR and hugely dilated. This is a 25 seconds video. I am sharing it. They are superimposed to know the LVOT obstruction. So this is you can see that. huge. The both transapical and transeptal, and transapical is snaring it. And according to CT image, you have to go over which view you want, and where the annular plane, that ring part, where the previous biocore area, you have to make it 80% the left atrium, left ventricle, then 20% the left atrium. But here it is little bit down to the LV. And is the post-procedure MR is regress, you can see the AST defect. And the post-procedure, you can see there is no MR, and the AST almost closed with a mild residual shunt. So to conclude, especially in our scenario, after the bioprosthetic failure, MVR or in the valve ring are more challenging than the aortic valve in wall, but with many advantages like avoid redo surgery, the shorter duration stay, and the operation time, and also evidence of the blood transfusion. So the optimizing the patient selection, that is understanding the valve and ring suitability and procedure planning will improve these mitral valve in wall or valve in ring outcomes. Thank you for the patient attention. Thank you.
Excellent talk, Dr. Ashraf. My only question is, how often do you encounter complications in these patients, and how do you tackle them?
I have only limited experience. I think Dr. Anantharaman will be, but I can tell you the complication majority are LVOT obstruction. So LVOT obstruction you can definitely easily detected by the CT superimposition, and if at all, if it is more than 1.9 centimeter square, then the chance is less. And if the AML is less, and the angle also important, apex to the mitral annular, the plane angle is also is a matter. And and again is a thrombus, and the stroke is very high because especially these sort of patients with LA thrombus. To avoid LVOT obstruction, especially the technique of checking the LVOT is very, very important. It should be the mid systole or not the end systole, because end systole the majority of blood is going into the aorta. So just before that, mid systole or later part of the end systole, where the maximum aortic valve is open, that area you have to measure and critically analyze. There is a flow chart for that, and if it is more than 200 millimeter square, definitely LVOT obstruction is very, very less. Then now people come with the lot of Lampoon technique, and it's variation of the Lampoon technique. So I think Dr. Anantharaman will add one point.
Sorry, you go on. Yes, sir. Apart from this LVOT obstruction, so what are the other usual complications because of the adjacency to the other structures like LCX near the AV groove, conduction system?
All any structural intervention, conduction system, even coronary issues can occur, conduction system. If the left atrium is too much, very hugely dilated, many of the patient, and the right atrium will be small or even slightly dilated. In that case, for punctureitis, again, there can be issues like AV node, and also compression nearby the structure like coronary is all possible. So that's why the CT is very, very mandatory, and people even superimpose the CT image while doing the procedure to avoid the complications.
Yeah. So what we have in India at the moment, the mitral solutions is, if the patient had a previous surgical valve, you can do a mitral valve in well. If they had a ring, especially a semi-rigid ring, because the rigid ring will not become circular, so the most suitable one is a complete semi-rigid ring, then you can do a mitral valve in well. If you have mitral regurgitation with prolapsing segment, then mitral clip can be done. So only these three are available as mitral solutions. Total mitral is still not available in India, and US, UK, it's still in study stage. The potential issues, first thing is, you need to know exactly what valve is used, surgical valve. Second, how the valve is oriented when the surgeon did it. If he is oriented towards the LVOT too much, that will give trouble. Third thing, how the surgery is done. Was it done through opening the intra-atrial septum and surgery done? All these things, how will affect is, the transeptal puncture is the most crucial part of a mitral valve procedure. When you cross from right to left, the transeptal, if the surgery was done through the transeptal approach by the surgeon, it would have scar, calcium, so you won't get a perfect transeptal approach. If you don't get a good trajectory towards the mitral valve, so it has to be an infero-posterior puncture, or posterior and mid to inferior. If your puncture is not good, you will struggle For a mitral valve in valve, for a mitra clip, everything you will struggle. So that's the first part where you get issues. Then the second part is the neo LVOT. The neo LVOT, if it is more than 250, you will not have issue. 170 to 200, 250, acceptable. Less than 170, you will have potential issues. If the patient had a sparing surgery, caudal sparing or mitral valve surgery where the AML is still there, then you can do that lampoon where you lacerate it. We are having a new device that is come up. It's licensed. It's a shortcut device, which will be available next year in India, where you can go and cut the aortic leaflet if it's an aortic problem. Mitral leaflet, it's mitral problem. It's a surgeon's kind of scissor, but on a catheter. So it's a shortcut device that will be there next year. So the potential complications are less. The only thing you have to remember is you don't go for a 50-50 implant in the mitral position. You need to have 80% into the LV and 20% into the LA. If you just aim for a 50-50 implant, you will get an in-out. The covered portion is only 50% in the balloon expandable valve. So there will be mitral regurg in and out. The other important thing is on the LV side, you should have a nice flared, because the pressure gradient from LV to LA is high. Unlike the aortic where you have a cylindrical deployment, the mitral you need to have a flared up. So towards the LV it should be flared up. So here if you have a 25 valve, you can go with a 26 valve. So bigger valve. These are some simpler things.
And potentially too, the left thrombus and also paraprosthetic regurgitation previously, don't attempt. So it won't seal.
Otherwise it's very safe procedure. For all purposes it's a venous procedure. Very nice presentation, fantastic case. Thank you. I think we'll close this session because of the time and over to.
Yeah, thank you, chairpersons and speakers. Now we are moving on to the inaugural ceremony, and I take the real pleasure to invite the dignitaries onto the dais for the same. I'd like to invite Dr. Shashikumar M., President, ICC Kerala Chapter, onto the dais. Let's invite.
A warm welcome to Thiruvananthapuram. So after several years, a major cardiology meeting has finally came back to Thiruvananthapuram. It's a very nice day out there and a very good ambience inside the hall. It is really happy and enlightening to see all the dear friends and teachers assembled here. We know that in this field of information technology, the information is always available at your fingertips. So people may find what is the need of attending conferences like this. And in the future holds even bleaker because now the chatbots are available. That is there to take care of whatever lack of knowledge that you have. But still, the face-to-face interactions, the building up of the camaraderie, the seeing your old friends, and bridging the network is even more important as the times goes on. So, dear friends, the meetings are important, and we should attend these kind of meetings and should have a face-to-face interaction between our friends. So with this short introduction, let me go to my proper duties. I am sure that none of you require any special introduction to the dignitaries assembled over this stage. First, I would welcome our dear President, the dynamic President, Dr. Shashikumar sir, to this stage on the behalf of ICC and on behalf of all the members of the organizing committee. I extend a warm welcome to our dear President, Dr. Shashikumar sir. Dear friends, we have the chief guest here. It's none other than our national president of ICC, Dr. Jayagopal sir. Sir, I extend my warm welcome on behalf of the ICC and the organizing committee to you, sir. Welcome, sir. And the Then I would like to welcome our incoming president, the dynamic scientific committee chairman of today's meeting, Dr. Vinod Thomas. So I also welcome Dr. Vinod Thomas to this meeting. I will cut short the rest of the things. So a warm welcome to my dear friend and secretary, Dr. Placid, the treasurer, Sujay Ranka, and you can see the dynamic organizing committee chairman, Dr. Arshad. A warm welcome to all of you. And no meeting is complete without the with participation of the delegates. So we can see that in spite of the difficult time, a good number of delegates has come here from all parts of the Kerala. So a very warm welcome to all of you. Thank you. Jai ICC.
Thank you. Thanks for making this event a very graceful one by spreading the light. Yes, and now may I request Dr. Shashikumar M to the inaugural address.
Ladies and friends, I thought Mangalanandan is going to give us a heavy tea with a lot of pastries and cake. And I thought, following that, it will be right for me to speak on triglycerides. I think as president of the Indian College of Cardiology, I need to speak a few words. I'm immensely happy to see that the Indian College of Cardiology is progressing from pillar to pillar over the years. Scientifically, academically, and socially, we have become closer and more progressive. I must say that every year, the scientific content of the conference is becoming increasingly popular. And I congratulate the organizing committee and the scientific chairman for including so many topics of great interest. And without prolonging the talk, I declare this conference as open and inaugurating this conference. Thank you.
Thank you. Now, let's invite our beloved ICC National President, Dr. Jayagopal PB, for the keynote address. Thank you.
President of the ICC, Dr. Shashikumar, the Secretary, Treasurer, and all the office bearers, my dear senior colleagues and dear friends, It's a proud moment for me to stand before you and address this state conference. Well, I really go back to the past history of ICC. The ICC had its root in the early 90s, and I happened to be one of the founder members when Dr. Sadaksharappa had the brilliant idea of those days that this should be an organization mostly for the cardiologists. And at that point of time, it was thought that people with a cardiology degree or an MCH, cardiac surgeons, were an integral part, and even anesthetists. So that's how it came back, and we're happy to tell you that we are celebrating our 30th year. And this year it's going to be one of the major conferences in Bangalore. So, and I'm indeed happy that the ICC Kerala chapter was born when subsequently, and then it's really grown in structure. And when you compare with other chapters in the country, it's gratifying to see that this has really grown big and has been doing a commendable work. Well, I mean, none of us have any doubt about the educational capabilities and the kind of quality of work and the deliberations and the conferences that we hold in Kerala, for that matter. I think we have always been a role model, and I think ICC should continue to strive for that, and I really think that we should take this to much further heights. But I think one of the areas where I really want people to really, at least the organizing part of it from the state, is to think of doing something which will make us nearer to the public and probably dearer to the public. And that I would think it will be in terms of some measures, public education. For example, I had an opportunity to be at the ACC Board of Governors meeting once. And then the whole emphasis was on the advocacy and advocacy that you're trying to give it to the government. So I think at this point of time, we have still no kind of influence on any policy decisions. And I think this is the opportunity for us to really work hard and then do something. I must congratulate Dr. Shashikumar for having done a wonderful work this year. I think a very, very novel way of initiating public health education to school children. In fact, he targeted 11th standard students this year. And of course, I couldn't do much, but then we were all so happy to be part of that. And I think there is no better way than trying to mold the younger generation into a much more disciplined society. So I think congratulate you once again, and hats off to the ICC for such an initiative. So I don't really want to take too much of your time. The organization part has been done extremely well. Dr. Arshad, I think, a fantastic job, the real good ambience and the whole, and it's an educational feast. Dr. Vinod, I think you also done a tremendous job. I'm sure you're really spent a lot of time looking into everything. And I see a real good gathering. In fact, I was just mentioning to someone the other day, I was one of the large interventional meetings in the country a few weeks ago with a lot of cases, a lot of faculty, but I think the hall was, even the main hall was looking relatively empty. So I think that's really disheartening. But today, I think when we have this kind of focus, smaller meetings and a camaraderie, I'm sure this will take us to much better heights and a better tomorrow. Thank you all. And JCSI, ICC.
Thank you, sir, for your kind and encouraging words. Now, let me invite Dr. Vinod Thomas, Chairman, Scientific Committee, to address the gathering.
Respected dignitaries on the dais and off the dais, thank you all for coming for this conference. And we have a very good scientific agenda, and we have a pretty good number of faculty and delegates. So my only request is, please avoid, the hall is divided into two halves. The second half is for lunch and this thing only. My only request is for the faculty and delegates is that please avoid cross talks with industry people just behind the hall, so that the background noise is a little bit high. So my request is, if we can avoid that talk, the industry people will go outside. That is their designated area. So I request the industry people and all the faculty and delegates to avoid cross talks in the second half of the hall. The industry area is outside the hall, so that will help to maintain the sanctity of the conference. Thank you.
Thank you. Now, may I request Dr. Placid Sebastian, Secretary ICC Kerala Chapter, to speak a few words.
Respected President, ICC Kerala, Dr. Shashikumar, Chief Guest of the Day, Dr. Jayagopal, ICC National President, the senior dignitaries on the dais, faculty members, and delegates of ICC. It was an eventful 2 years of ICC Secretary's post I held for the last 2 years. The first year, I had the leadership of Dr. Binu. We conducted the ICC State Conference at Taj Bekal in an explanatory manner by Dr. Ramakrishnan as an organizing secretary. And ICC, for the last 2 years, have done quite a lot of public work, as well as we had a membership drive. We enrolled another 30 members, and the total strength of the ICC is now around 170. And I'm sure the next organizers and next executive members and members of the ICC will take it up to 300. And also an important event which took place last year was our national conference. And the organizing committee has done a wonderful job, and it was one of the best rated ICC meeting. And this year also, I think the organizing committee has done a good job with a good scientific content and an excellent venue. I thank you all for coming to this meeting and making it a big success. Thank you.
Thank you, sir. Now, let me invite Dr. Arshadem, Organizing Secretary, to deliver the vote of thanks.
Good morning, respected teachers and dear friends and colleagues. I really consider this as a journey which I never traveled after my 10th standard. And so after completing this, in fact, it's probably a 10 months journey. After completing this, I'm feeling only one feeling, gratitude towards a lot of people. In fact, I have listed a lot of people here. And to start with, in fact, when Ashwin sir called me up 10 months back and told me, in fact, Arshad, whether you can take the post of organizing secretary this year, in fact, straight away I said yes. But next day onwards, anxiety popped up. In fact, I really was not knowing, in fact, how I will conduct this because I didn't have any previous experiences. And so that moment, in fact, two guys from Trivandrum, in fact, just called me up and said, Arshad, you don't have to worry. You just go ahead. We are there with you throughout. Right and left, it's none other than Dr. Binu and Dr. Mangalji and Mangalandan. And they really kept their word. In fact, all throughout, in fact, during these 10 months, in fact, they were with me right and left. And thank you, Dr. Binu and Dr. Mangalandan for that. And next, definitely another best thing which happened to me during this conference was our President-elect, Dr. Vinod Thomas. And of course, he is the scientific committee chairman also. And a very balanced person, as you all aware, in fact. And whenever I said something good, he said, Arshad, go proceed. It will definitely work with the people. And whenever I said something not very good, he say, no, Arshad, it won't work with the people. In fact, you just hold it on. So that way really, it really balanced the whole situation. And we really have a good conversation during this period. Our talks really extend from 11 o'clock at the night towards the midnight and past midnight also. But it was really good to to make the scientific agenda with him. And I really am indebted to that for Dr. Vinod Thomas. And of course, I should thank the ICC Kerala the executive committee members also, whether it is President Shashikumar Sir, Secretary Placid Sebastian, Treasurer Dr. Sujay Ranga. All these people were, though they were working at a very distant place, but they were just a phone call distant. In fact, whenever I talked or whenever I called them for something, they instantly replied me with this help and any WhatsApping or something. In fact, they were instantly replied me with the help. And of course, I need to thank you for that, for all the ICC Kerala executive members. And then I should thank Trivandrum cardiology people. In fact, all the people, whenever I talk, whenever I approach them with any help, in fact, even for the industry meet, in fact, senior people turned up for that. In fact, thanks from the bottom of my heart for the Trivandrum Cardiology Group for being there with me throughout this journey. I should thank my own people at SK Cardiology, we used to call elder brother and younger brother, my elder brother Suresh sir and younger brother Harihara Subramaniam and the team of SK, whole team of SK nursing staffs or staffs, nurses and all, and junior doctors. In fact, they helped me immensely during this journey. And of course, the speakers, I should thank them. In fact, they had a long journey to reach Trivandrum. And so thank you, Dr. Anandaraman and Dr. Sai Sadish, who is going to come tomorrow, and for making this possible. And of course, all these conferences definitely involves a lot of financial things, and without pharma people, we really cannot do this. And all the pharma guys, in fact, when I approach, 90% of them approached with a positive manner, and we could gain, in fact, whatever which is possible for this conference. And thank you, pharma people, for the bottom of my heart. And of course, a word of appreciation or word of thanks to my family, my wife and kids. They were also there with me, and they were doing some clerical jobs and finding out, even helping me out in preparing some Excel sheets and all. They were, for the last 2 months especially, they were with me throughout. Thank you for that. And of course, I think the lubricant of the whole system was Mr. Anish. He was there throughout this whole journey, and he really made the things very simpler, and thank you, Anish, for that. And of course, I need to thank Mr. Moses and team for audiovisual, for the better audiovisual facility, and Sunita Menon from media, and Tennyson Group for the sound system, and Cameo Group Srijit for the light, and Sandeep for making the stage and the production work better, in whatever way best which is possible. And of course, I should thank the Axis Bank for the financial assistance, and also the Jibu Travels for the making fantastic travel arrangement, and Mr. Hidayatullah and the team of Hayat Regency. Hidayatullah is the manager for the team, and for arranging all the things possible, and they were with me throughout this journey. And last but not the least, in fact, I should thank all the audiences, in fact, sitting here, in fact. And as Jay Gopal sir has pointed out, in fact, I know that in fact there were some parallel conference, some way it collapsed, collided with some other conferences. But just by the announcement, only some people, even seniors, in fact, gave me a personal message saying that, Arshad, we will be coming to the ICC cardiology, don't worry. And we really want to go for the other conference, but we will be skipping that for this year, in fact. That really shows how well our cardiology camaraderie is at our Kerala district. And thanks Almighty for making everything possible. Thank you.
Thank you everyone. Now I request Dr. Shashikumar to kindly stay back on the stage, because it's presidential oration now, and I would like to request the chairpersons, Dr. G. Vijayaraghavan and Dr. K. Venugopal, onto the dais, please.
Welcome to the presidential oration. I'm very happy that my friend Dr. Shashikumar is giving the presidential oration, and he doesn't need any introduction as such. Shashikumar was my colleague when we started KIMS. Brigadier M. Shashikumar, MD-DM, product of AFMC Pune. After DM cardiology, he's been practicing cardiology for the last 39 years. Former professor in HOD cardiology, AFMC Pune, Pondicherry Institute of Medical Sciences. He had been examiner for MBBS, MD, DM, and DNB. Past president of CSI Pune, CSI Kerala, and Cochin Cardiac Forum. Presently, president Indian College of Cardiology, Kerala chapter. Working as consultant in cardiology at Medical Trust Hospital and VKM Hospital, Tripoli. Dr. Shashi, more than anything else, is a very good friend. Welcome, welcome Shashi, and please, this is yours.
Thank you. Respected chairpersons, ladies and friends. Today, I would like to discuss about triglyceride. The simple structure of triglyceride is 3 fatty acid molecules covalently bound by a molecule of glycerol. This is synthesized in the liver by the unused calories we take, and also taken up by the liver by the dietary sources like fats, butter, and oil. It is
not soluble in water. As a result, it is circulated all over the body, bound by a protein, lipoproteins. And it is either given as an energy whenever it is required or get deposited in the fat cells. The normal level of triglyceride in adults is less than 150 milligram. It is mildly high, between 150 to 200, and it is moderately high, between 200 to 500, and very high, it is over 500 milligram per deciliter. It is an independent risk factor for coronary artery disease, stroke, vascular disease, and pancreatitis. In combination with other additional risk factors like increased cholesterol, like increased LDL, or low HDL, or other risk factors, it becomes much more dangerous. This is the picture of the triglyceride content of an atherogenic lipoprotein. Other than HDL, the total cholesterol minus HDL is the atherogenic lipoprotein, and the triglyceride contents gradually reduces from chylomicrons, which is around 85%, to 5 to 10% in the HDL. It's gradually the triglyceride content comes down. The classification is the hyperlipidemia is Frederickson classification. The most common one is class 2B, where both triglyceride and the cholesterol are elevated. Very, very increased triglyceride is in type 5, where the triglyceride content is over 1,500 to 2,000 milligram. Elevation of triglyceride commonly doesn't produce any symptoms unless it is elevated very high. Then if it increases more than 1,000 milligram, generally it can produce symptoms like nausea, vomiting, respiratory distress, eruptive xanthomas, corneal arcus, lipemia retinalis, scandalisma, and neurologically can produce memory loss or dementia. One of the causes for increased triglyceride is enzyme-dependent causes like lipoprotein lipase deficiency or liposomal acid deficiency. But however, these things are not very common. The most common one are the non-enzyme-dependent hypertriglyceridemia, which is basically the insulin resistance, diabetes, obesity, high carbohydrate diet, and then excess of alcohol, nephrotic syndrome, hypothyroidism, glycogen storage disease, Cushing's syndrome, multiple myeloma, etc., etc. Amongst the drugs, what we have is commonly used thiazide and chlorothiazide diuretic, high dose of beta blockers, bile acid sequestrants, glucocorticoids, atypical antipsychotics, oral estrogen and contraceptives, then HIV treatment drugs and immunosuppressive agents. The metabolic syndrome, which is characterized by abdominal obesity, hypertriglyceridemia, hypertension, and prediabetes, are the most potent cause for atherosclerotic coronary artery disease and so many other disorders. Here again, the triglyceridemia is an important factor, and the association of triglycerides in women and the other risk factors like obesity, diabetes, and hypertension are much more potent among women as compared to the men. As far as the treatment strategy goes, the important treatment strategy for the treatment of atherosclerotic cardiovascular disease in hypertriglyceridemia is implement the guideline-directed statin therapy or optimize statin adherence. So that is the basic guideline, is treat with statin. Whatever is the amount of elevation of the triglyceride, whether it is 500, whether it is 500 to 1000, or whether it is over 1000 milligram, whether it is associated with the diabetes, whether it is associated with coronary atherosclerotic coronary artery disease, or even without any other disorders. The main strategy is lifestyle diseases, lifestyle control, the dietary changes, and control of diabetes, and then statin therapy. In spite of treatment with statin, if the triglycerides are going to come down, then you can refer the patient to a better center for specialized in these management strategies. The non-pharmacological treatment basically comprises of dietary changes, weight reduction, exercise, and avoidance of alcohol. The pharmacotherapy, as I mentioned, is basically statins, fibric acid derivatives like fenofibrate, and omega-3 fatty acid. The physical activity definitely plays a major role in the management of triglyceridemia. An activity of 30 minutes a day or 150 minutes per week is very important in management of hypertriglyceridemia. And along with this, a weight reduction of 5 to 10% generally brings down the triglyceride by 30%. A trial which is a reduced sign, where they have compared the double-blind controlled trial, whether they treated a 50% patient with icosapent ethyl ester, high doses, 4 gram, compared to a placebo. And they found that the treatment with this medicine will reduce the primary endpoint by more than relatively risk reduction by 25%. And as far as the secondary endpoints are concerned, it reduces the risk by 26%. Another trial, the STRENGTH trial, which showed a randomized controlled trial with omega-3 fatty acid and corn oil, and they found that although it doesn't produce any major benefit in comparison with the placebo. The last trial what we have is on pemafibrate, a comparison of pemafibrate with people with increased triglyceride with a reduced or normal HDL or LDL showed that although it reduces the triglyceride level all right, but it's not going to produce any major benefit in the primary endpoint like non-fatal MI, ischemic stroke, coronary revascularization, or death. So though it reduces the triglyceride, it doesn't produce any cardiovascular benefit. A healthy dietary pattern, as I mentioned, whatever is the amount of, the level of triglyceride elevation, whether it is mild, moderate, or higher, or very high, what we need is relatively, progressively reduce the added sugar. Depending upon the level of triglyceride, you need to reduce the sugar. And so is the total fat and alcohol. If the level is very high, you need to abstain. If it is moderate, you need to reduce. That is what you need to progressively reduce this diet, including sugar, fat, and alcohol, and nuts, especially the other glycemic index vegetables, like high glycemic index vegetables, like carrot, potatoes, sweet potatoes, yams, and high glycemic index fruits, like mangoes, pineapple, watermelon, and ripe banana. These things should be gradually reduced or stopped if the level is very high. And exercise, as I mentioned, definitely plays a major role in the reduction of triglyceride level. As I told you already, it reduces the triglyceride level by 30%. A weight reduction is also an important strategy in bringing down the triglycerides. And maximum statin therapy, as per the guideline, need to be given. That the first aim is to bring down the LDL level, and then probably you can look into the triglycerides. You can also consider icosapent ethyl or omega-3 fatty acid or fibrate in case the level is not coming down by the statin therapy alone. So in conclusion, I say the triglycerides are very, very important, responsive to lifestyle changes, weight management, glucose control, physical activity, and abstinence of alcohol. One must look for secondary causes and review the medications before giving further treatment, and optimize guideline-directed statins to achieve LDL control target. Prescription of omega-3 fatty acids are recommended instead of OTC or over-the-counter fish oil, and fenofibrate is the preferred fibrate agent in final treatment of hypertriglyceridemia. Thank you for your attention.
Brigadier Shashikumar, it's very important. You touched a part of lipids and its management, which is not often discussed in meetings like this. And on behalf of the audience, I would like to congratulate you for discussing this rarely touched topic. For orations, normally no questions are entertained. Any doubts you have, you can have while during the lunchtime. And thank you, all of you, for the patient listening. Thank you, Brigadier Shashikumar, for enlightening us.
Thank you, Dr. Brigadier Shashikumar, for an excellent overview of the triglyceride saga, as I would say. We have always considered triglyceride to be a ill-treated sibling of total cholesterol. We have never given so much importance to triglycerides as has been given to cholesterol, but as you have very clearly demonstrated, it has now become one of the most important aspects of preventive cardiology to prevention of cardiovascular diseases. With these few words, let us conclude this session, and thank you once again for an excellent presentation.
Thank you. And now I request Dr. Vijay Raghavan and Dr. Venugopal to present a memento to Dr. Shashikumar. Yes, I request both of you, Dr. Vijay Raghavan and Dr. Venugopal, to present a token of love to Dr. Shashikumar on behalf of ICC Kerala chapter, and we may witness this lovely moment with once again a big round of applause. Everyone, please. Thank you. Yes, now we may move on to the next session, and I would like to invite the chairpersons, Dr. Meera R., Dr. Sajan Ahmad, Dr. Deepu Rajendran, and Dr. Rajesh Kumar onto the dais, please.
Good morning, everyone. It's a wonderful venue and wonderful topics. We will go to the next session, two important areas. First, we would like to invite Dr. Arun Gobi to talk on LV dysfunction and need for pacing. How will I do physiologic pacing?
Respected Chair, teachers, colleagues, a warm good afternoon. So to set the preamble for my talk, let's go through a case scenario. Middle-aged person, complete heart block, mild LV dysfunction, comes to the primary cardiologist, undergoes an angio, which is normal, undergoes a dual chamber pacer for the complete heart block, gets an RV apical pacing done. Within 6 months, comes back with heart failure with this echocardiogram, severe LV dysfunction. You interrogate the device, fully paced, lot of episodes of AF on the device, and gets referred for further management because of refractory heart failure despite a guideline-directed therapy. So the villain in the story is actually RV apical pacing. So RV apical pacing, as you all know, induces electrical dyssynchrony, leads on to mechanical dyssynchrony with a delay in the contraction of the basal lateral wall, which leads on to LV remodeling, functional MR, LA remodeling, and atrial fibrillation. David Trial gave us this information about 2 decades back with RV apical pacing causing heart failure and AF. Most gave us further insights with more than 40% pacing requirement patients developing heart failure and more than 80% pacing requirement patients developing atrial fibrillation. So this concept of pacing-induced cardiomyopathy variably defined, an absolute value of EF less than 50% or a 10% drop in EF being the most commonest definition. But a lot of studies use various definitions, and the incidence also varies between 10 to 20%. And the basic risk factors include the pace QRS duration and the percentage of pacing. But in fact, asymptomatic perturbation of myocardial function happens as early as 1 month after pacing and is a universal phenomenon. So device companies understood this much earlier. They tried to use various algorithms to reduce RV pacing. In fact, they were trading VV synchrony towards AV synchrony. And obviously, as expected, it backfired. The short-long sequences that these algorithms of minimizing ventricular pacing did, actually the short-long sequences caused an R-on-T phenomenon and polymorphic VT. So it was like a pacing paradox. You implant a pacemaker to pace, and then you're instructing the RV lead not to pace. And in trials, this didn't work out. So they went into moving from the apical side towards non-apical side, like septal pacing, outflow pacing. But again, none of these stood the test of time because of non-standard practices. CRT is a time-tested therapy with more than 20,000 patient data. But again, an implanter knows that about 1/3 of patients don't respond to CRT. Lead distortion rates happen to the rate of 3 to 10%. There are challenging venous anatomies leading on to high LV thresholds and phrenic nerve capture. So there's definitely a gap in the pacing therapy which needs to be filled in. And this new kid in the blocks, physiologic pacing, either by pacing the His bundle or left bundle pacing, comes in this scenario, with an idea of eliminating the risk of pacing-induced cardiomyopathy in Brady patients and improving resynchronization in heart failure patients. Essentially, we're trying to replicate what God has done to our body, because evolution has taught us that His-Purkinje system is the most efficient way to depolarize the ventricle, and we are trying to do that with physiologic pacing. So essentially, with resynchronization, what it does is, we know that the fibers designed for left bundle or right bundle are actually pre-designed or dissociated way high up in the proximal His bundle itself. And most of the people with left bundle branch block, the site of block is very high in the proximal His bundle. And so you can pace distal to site of block and resynchronize the ventricle. Although we are talking about this in 2023, this concept was known to us about in 2000 itself, because the first series was published in 2000 by Deshmukh on a series of 18 patients. And this is a site of pacing. You try to pace in the membranous septum between the RA and LV, trying to target the penetrating bundle of His with this kind of EGMs, a small a, a sharp His bundle potential, and a larger V, and that's where you're trying to target, and these are the pace QRSs. You won't even believe that these are pace QRSs, except for that you find the pacing spike essentially looks like the sinus QRS, very narrow and sleek, and this is what a physiologic pacing does. For beginners, you have a 7 French external sheath, a peel-away sheath placed in, and through this sheath you take this dedicated conduct system pacing sheets, which are available from different vendors. Most of them are 7 French sheets. You take it to the site of pacing, and so here you have the sheath coming in. The beauty of this is you are pacing the ventricle from the atrium. So you're actually pacing the His-Purkinje system from the right atrium. You're not crossing the tricuspid valve. There are no tricuspid valve related issues. So you have this lead which is designated for conduct system pacing. You try to take it to the site of His-Purkinje, the membranous septum, between the RA and LV, take in the lead here, prepare for unipolar mapping, in which you have the black tip designated to the tip and the red to the body, and then you have this site which shows the sharp His-Purkinje potential, which is going to be a site of pacing. And once you position the catheter there, then actually fixation is just by rotating the lead. This is how you fixate this lead, by clockwise rotation to fix the lead in. And while you're doing this, you're monitoring the impedance, you're monitoring the pace QRS, and generally when you're going in, you actually find a drop in the impedance, which ensures that it's fixated well. And contrary to what you find is here, the injury current is not in the myocardial tissue, it's actually in the His-Purkinje signal. The His potential, you can see an ST elevation which ensures that you are screwed in well to the His. And once you're in the correct position, then check the electrical parameters, and then taking out the sheath is just like how you slit a CS sheath. Just slit the sheath out, and then you are done with the conduction system pacing. So this is the lead that we use. It's a 4.1 French bipolar, 59, 69, and 74 centimeter length, lumenless, exposed fixed screw lead with a helix of 1.8 mm and tip to ring distance of 9 mm. And this is a sheath from Medtronic, which is a 315 sheath, a 7 French outer diameter, 5.4 French inner diameter, 43 centimeters. Biotronic gives Selectra 3D sheets, 3 different curves, 3 different lengths, which allows their Solia pre-shaped lead. And the Abbott gives the Agilis His Pro sheath, again allows their conventional lead to be placed in. Boston gives 4 kind of sheaths. The one sheath is for his bundle. The second sheath is actually for left bundle in normal heart. 3 is for the left bundle in larger hearts. And the 4 sheath is for the right-sided conduct system pacing. Essentially takes the Ingevity leads in. And so when you have His-Purkinje pacing, you have a pacing spike followed by an isoelectric line, which is equivalent to the native HV interval, and a narrow QRS, as I said, just looks like a native sinus rhythm beat. For non-selective pacing, you have a slurred upstroke of the QRS because of the simultaneous depolarization of the myocardium there, and then you have a very narrow QRS with similar axis. But His-Purkinje system has its own limitations. About 20% of time, you won't be able to achieve it. You have late rise in thresholds in about 15% of patients requiring lead revisions. Atrial oversensing, ventricular undersensing are all its problems. And so that's why now we go a bit down from the His bundle, going to target the left bundle. Essentially, this is a site about 1.5 centimeter infra-apical from the site of from the site of His bundle, and then we go down, ensure that measure the ventricular septal thickness on the echo, have a backup pacing if there's a baseline left bundle, locate this site, and then just rotate the lead. And as you rotate the lead on the LAO view, you can see the lead goes in well, the impedance drops, and as you reach the left side, you have the typical QR pattern, which ensures that you reach the left side of septum. So moving from the RV subendocardium, this is the signal. When you reach the mid septum, this is the signal. And when you reach the left side of the septum, you get this QR pattern. Also, if you're fortunate, you will find the left bundle potential, antegrade potential, or a retrograde potential based on how lucky you are. But one thing you have to measure is a similar to left LV activation time, which is from the pacing spike to the peak of R in V5, V6, which shortens as you go in. And at the final site, it will be the shortest and most constant at low output and high output. And if you think that only an EP can do it, it's no way. You don't need any of the EP system. You can just do fluoroscopically identify the location. This is your site. And then you go in, just screwing in, and just look at the pace morphology till you get the sharp QR pattern in V1. And that's how you can do a left bundle even in non-EP setting. If you are afraid of radiology, if you are afraid of the radiation hazards, you can do it zero fluoroscopy using 3D electroanatomic mapping as well. And now we have data that it resynchronizes well, improves ejection fraction, remodels the LV as good as a CRT. And from the initial scenario when it was used as a failed CRT option in cases where a CRT fails, now it has moved on. It is actually beating on CRT and becoming even better than CRT with some preliminary results which say that conduct system pacing is better than CRT. And if you see in the Indian scenario, this is a beautiful concept. It's actually a dual chamber pacer placed as a CRT. You just put a dual chamber pacer in this patient with 160 millisecond QRS, narrowed down to 90 milliseconds with just a dual chamber pacer, and his EF improves to normal by about 6 weeks' time. In addition, in people with DCM with non-LBV morphology, like a right bundle branch block, conduct system pacing will still be able to narrow and improve the synchrony in these patients. If you have an IVCD kind of QRS in which a CRT won't work, you can use the best of the both worlds. You can have a CS lead placed in, and you can have a left bundle lead placed in. So this is called a left bundle optimized CRT. We have a left bundle as well as the CS lead in. And so you can see this is the baseline QRS, this is the LB pacing, this is the LV pacing, and when you have LOT CRT or left bundle optimized CRT, there's no QRS as narrow as this. Now, what does the current guideline say? This is the latest HRS guideline, which says that class 1 indication heart failure is definitely CRT. While conduct system pacing gets a 2-way indication when CRT fails. In people with EF between 35 to 60%, conduct system pacing gets a 2B indication, and as an alternative CRT, it is still a class 2B indication. Being a newer technology, there are again concerns of how you would extract this lead and possibly an issue of lead fracture as seen in this scenario. But again, don't worry, there are numerous studies which are on the way, with about 25 studies underway, which will give us more information on these lines. So to conclude, RV pacing is associated with adverse clinical outcomes, including pacing-induced cardiomyopathy, atrial fibrillation, heart failure, and increased mortality. Physiologic pacing via His bundle pacing or left bundle pacing is the way forward for any patient who requires RV pacing, that is more than 40% pacing, especially in people who have an EF less than 50%. Conduct system pacing is a novel option for CRT or resynchronizing patients in heart failure who fail a BIV, who have a non-LBV IVCD or an RBV morphology, or patients who undergo an AV junction ablation, Or you can use the best of the two worlds as an add-on, as a lot or left bundle optimized CRT or a his bundle optimized CRT. Physiologic pacing is a new technology with emerging data, but again, there are concerns about long-term durability of the septal lead, issues with lead extraction, possible issue of lead fracture as I showed in, and possible thromboembolic risk if the lead gets into the LV endocardium. But currently, as we see it, conduction system pacing is likely to be the pacing modality of choice for all patients who require ventricular pacing, especially in the presence of LV dysfunction. Thank you.
Thank you, Arun. Thank you, Arun, for taking us through this left bundle pacing. I just had one query. The usual problems associated with conduction, left bundle area pacing is in presence of distal block. If the LBP is due to a very distal block in the Purkinje system, how do you circumvent it? That is number one. Second, if you have a very thick septum. So these two conditions, how would you like to circumvent?
Okay, thank you. Dr. Meera has brought up a very important concept, because the whole concept of His-Purkinje system pacing or left bundle pacing is based on the concept that always in patients with left bundle branch blocks, the site of block is the proximal His bundle. But most of the time it is not this scenario. You might have distal conduction system disease present at the site of implant or may develop in future. But what is seen is most of the people, the injury in the conduction system is finite. So if the person in the initial time has a proximal block, it is very less likely that he will have a distal block in future. So one way of identifying this is to do an EP study during the time of implant, where you can actually designate. If you put a quadripolar catheter across the conduct system, you can actually identify where the site of block is. In people with very distal conduct system block, conduct system pacing does not work well. The way in which you can resynchronize these patients is having a LOT CRT, where you can have a left bundle lead as well as a CS lead, which can actually in some way correct the distal block as well. But again, in people with distal block, conduct system pacing is yet to invent a therapy which can circumvent that. The second issue that Dr. Meera raised is the issue of thick septum. What we have realized is how much of a septum is thick, we can still penetrate, but the red flag is fibrosis of the septum or a scar in the septum. If we have done conduct system pacing in people with a HCM, people who have 21 mm septums, we are able to get through the left. It actually goes through butter. If you don't have fibrosis, if you don't have scar, you can get along. But even if you have a 7 mm septum, it is really scarred, you just cannot go through. So it's a scar in the septum which is a red flag and not the thickness.
Thank you.
Can I raise?
Please.
As an extension to what Dr. Meera asked, suppose you have trifascicular block. Will you be going with the same sort of approach of left bundle pacing? Second question is, do we have any chance of getting a left bundle plus right bundle pacing in the near future? Are we doing it, or is there any way of doing that? LB plus RB pacing.
Okay, thank you, sir. So again, Balashran sir said two important aspects. One is in presence of trifascicular block. How do you do? So the way we do it is, in a person with trifascicular block, we put in the left bundle lead, we pace it, we see whether we are able to narrow down the QRS with the left bundle pacing lead alone. That gives us a clear indication that our site of block is proximal to the site of where we are pacing. And so if we are able to narrow down the lead, narrow down the QRS with the conduct system pacing lead, then we stop there. The moment you have a narrow QRS, we ensure that there is electrical synchrony that translates to mechanical synchrony. If you are not able to narrow down, we put in a CS lead additional to get a LOT CRT that will synchronize further. The second question was, yes, so that's again, left bundle or conduct system pacing is an evolving therapy. There's now an entity called RB pacing, which is also coming up. And I'm pretty sure in the near future, you'll have more and more hardwares which are going to pace both. But in the same lead, if you look at this lead, this also gives us this ability, because the tip is actually in the left side, the ring is actually on the right side. So with this, if you use the anodal capture, you can circumvent the right bundle branch block as well, in this lead itself. But there are newer hardwares which are coming in, which will give us the ability to pace both sides.
Thank you. If cost is not a constraint, would you recommend physiological pacing for all patients with a pacing indication, regardless of the EF or the bundle branch?
Again, I would say that we are prematurely jumping into conduct system pacing, because this is a therapy which we have known only since last 6 years. The other therapies are known for more than 3 decades. So for all patients, I wouldn't say that you should use left conduct system pacing, because we don't know, because we are now now seeing case reports of lead fractures. We are now finding issues where we have difficulty in extraction of these leads. So probably once we have a 10-year follow-up data or more long-term data, then we can recommend it blindly for everyone. But at this moment, only for patients with failed CRT or as an add-on to CRT or in patients with less than 50% EF requiring more than 40% PC. Thank you.
So let's first welcome Dr. Nandakumar for his talk on an issue that we frequently face, the first episode of AF in a hospitalized patient, the anticoagulation and antiarrhythmic strategies.
Good morning, everybody. Thank you, organizers, for this opportunity. A day-to-day problem for all cardiologists, but often confusing situations and very little answers clearly in literature or in guidelines. That's how I would put it for this topic. First episode of AF in a hospitalized patient. This is basically a heterogeneous group of patients. So to have a standardized guideline or an action plan is often difficult. The definition or terminology itself in literature is a little confusing because AF occurring in an hospitalized patient has in some instances been called as new onset AF. It has been called as transient AF. It has been called as secondary AF when it occurs secondary to other medical illnesses. The new term which has come up in the 2023 guidelines, it has been introduced as acute atrial fibrillation, which is defined as atrial fibrillation detected in the setting of acute care or acute illness. Now, this atrial fibrillation may be detected or managed for the first time during hospitalization. It might have been previously existing, but we do not know, and it has been detected for the first time, or it may be secondary to an acute illness occurring at that particular point of time. Acute atrial fibrillation might be paroxysmal or it may be persistent as the time goes by. It may be symptomatic or in many instances it may be asymptomatic. But all said and done, there is a high risk of long-term AF recurrence in these patients and therapies need to be directed with this in mind. Atrial fibrillation occurring in hospitalization, this is probably the only specific guideline which I could get across in published in the Circulation 2023 March. Now the 3 A's of acute management is one, we need to look at the acute triggers. We need to identify and treat the triggers of atrial fibrillation. AF control, which can be achieved either by a rate control or by a rhythm control, and we need to also look at the anticoagulation management. Now, this is a conceptual model of substrates and triggers in acute AF. Now, how acute AF is different from a patient who has AF and is coming to you in an OPD is that here you have a substrate. On top of it, there are a lot of triggers like sepsis, infection, inotropes, bleeding, volume loss, pulmonary complications, pericardial or pericarditis or effusion. So all these put together in a substrate of a heart or in a milieu of a heart which has the substrates for producing AF, this is what triggers an acute AF in a hospitalized patient. So the potential mechanisms for development of acute AF would be in the presence of the acute triggers, you might be observing a previously undiagnosed AF, or there may be an unmasking of an underlying predisposition to AF. So this is what is basically the crux of the problem. So our efforts in an acute AF needs to be directed towards treating, identifying the triggers which have caused the atrial fibrillation. Now, how do we go about controlling the atrial fibrillation? We might opt for a rate control or a rhythm control strategy. If the patient is hemodynamically unstable, then it goes without saying that we need to go do a prompt electrical cardioversion. Otherwise, we can have time and we need to identify the acute triggers and direct our efforts towards it. We have to assess the impact of atrial fibrillation on the patient. If there is an adverse impact from tachycardia, which is worsening the patient's situation, then we might have to opt for rate control. If the adverse impact is more due to loss of AV synchrony, especially in the setting of heart failure, concomitant heart failure, then probably a rhythm control strategy would be better. Now, what depends whether we need to go, what decides whether we need to go for a rate control strategy or a rhythm control strategy? Generally, a first choice therapy for patients with minor symptoms would be, if they are asymptomatic, we may take a wait and watch approach and direct our efforts towards treating the triggers. The AF might respond on its own in some situations without even antiarrhythmic drugs or DC version. When we go for a rate control, we need to go for a lenient rate control with a heart rate control of around 110 beats per minute, because in these situations, often the increase in heart rate is because of other secondary factors like sepsis and hypotension or other concomitant illnesses. Now, for patients who have symptoms and who have deterioration of LV function or who are on CRT, we may have to go for a more aggressive control of the rate with a heart rate of lower than 80 beats per minute. In a post-cardiac surgery situation, a rate control of 100 beats per minute is what is recommended, and optimal heart rate needs to be individualized with regard to the underlying conditions. Now, what are the drugs which are available for rate control? I'm not going into the details. Beta blocker is the drug of choice, especially in situations when there is a concomitant heart failure. In COPD patients, you might use a non-dihydropyridine calcium channel antagonist. Digitalis is a third drug of choice because of the slow onset of action, the time it takes to bring about rate control in an acute setting. Sometimes in patients who don't respond to all these measures, you might be forced to use amiodarone as a rate control measure itself. Now, what is the choice of drugs for rate control? I just mentioned the first line would be beta blocker or NDCC. In hypertensive patients with preserved ejection fraction. In heart failure with reduced ejection fraction, we choose a beta blocker, and this algorithm finally leads towards digitalis and amiodarone. And as a last resort, on a long-term basis, we might consider AV node ablation with implantation of a pacemaker. Now, which are the patients who need a rhythm control in an acute AF situation? Now, factors favoring rhythm control are younger age group, first AF episode or a short history, a tachycardia-mediated cardiomyopathy, no or few comorbidities or cardiac illnesses, because the chance of recurrence would relatively be less in these patients if you restore the rhythm. AF precipitated by temporary events or acute illnesses, again, rhythm control would be a better option. Normal or mildly increased LA volume indices or a limited atrial remodeling, these patients we plan for a rhythm control. And in patients in whom rate control is difficult to achieve, we might be forced on a long-term basis to go to rhythm control. Now, patient choice also needs to be looked into, and we need to discuss the implications of anticoagulation when we go for a rhythm control. The drugs which are available are flecainide, propafenone, amiodarone, and ibutylite. Most commonly in our settings, we use amiodarone because of the availability issues and the side effects. When you go for electric cardioversion, the anticoagulation status of the patient becomes important. We need to start anticoagulation 3 weeks prior to if for an elective cardioversion, and follow it up for at least 4 weeks of anticoagulation after the DC version. In patients who are in less than 48-hour window period, we can anticoagulate and do the DC version relatively sooner. In anticoagulation for acute AF, we need to balance the risk of thromboembolism against the risk of bleeding. So it has to be a shared decision making. Generally, patients with a CHA2DS score of more than 2 in men and more than 3 in women need aggressive anticoagulation. We need to counterbalance it with the Hasbled score, which increases the risk of bleed after 3. In acute illness settings, we need to individualize, because the prothrombotic and coagulopathic milieu may differ, and peri-procedural hemostasis also needs to be looked into, especially in post-op patients and post-cardiac surgery patients. Now, the anticoagulation choices which we are going to have a detailed talk about the choice of antibiotic. Generally, NOACs are preferred over and above the conventional vitamin K antagonists because of their safety. And these days, we can even go straight away to NOACs even without overlap with heparin or low molecular weight heparins. Now, management considerations in specific situations, emergency departments, critical care ICUs, lot of other patient factors come into the picture, and we need to be very clear that it is not only about the rate or rhythm control or anticoagulation. We need to balance it with the underlying illness which the patient has. COVID-19 had thrown up its own challenges. Hyperthyroidism, again, a lot of issues are not very clear in guidelines because whether we need to continue even after the euthyroid state is attained or not, these are all questions subject to future research and studies. Stroke situation, again, we have the risk of re-embolization is slow, and the neurologists always want to delay anticoagulation sometimes because of the risk of hemorrhagic transformation. In non-cardiac surgery patients, after surgery when they develop AF, we need to look into the bleeding risk from the surgical point of view. So at the end of the day, it is always a teamwork in an acute setting when we have to manage AF with a collaborative effort from all departments. This is the care of pathway in nutshell. To summarize, the 3 A's of management of acute AF in hospitalized patient. Long-term follow-up, you have the 2 M's, monitoring and modification of therapy. And to summarize, the 3 A's and 2 M's which you need to keep in the setting of acute AF. Thank you.
That was an excellent talk regarding a difficult topic in which we will encounter in our day-to-day practice, but the decision making is very difficult. I have one doubt regarding a patient with a sepsis. He has got noticed a first episode of AF, but that has been reverted spontaneously without any intervention. Then what should be our strategy of long-term anticoagulation?
As I was mentioning, these are all subject to the individualization. In a particular situation, as you said, in sepsis, the AF would have been triggered by a lot of biochemical cascades happening in the patient. The increased adrenergic drive, the use of inotropes, all this would have contributed to the occurrence of atrial fibrillation. So since it has spontaneously reverted, we have to consider whether this patient will be a good candidate for anticoagulation or not. Now, unfortunately, in the setting of AF, prevention of stroke, the incidence is almost twofold in the setting of sepsis, but we do not have evidence that aggressive anticoagulation in the setting of sepsis will prevent stroke in these patients. So it's double-edged. On one hand, you have an increased incidence of stroke in septic patients, but at the same time, aggressive anticoagulation may not work out in favor of the patient. So it has to be individualized in a given situation, whether you need to be aggressively treating or not. Since the patient has already reverted spontaneously, we might focus our attention towards rate control with beta blockers and hope that the crux is to aggressively treat the sepsis. Once the sepsis subsides, the chance of AF recurrence goes down.
Essentially, treat the patient and not the ECG.
Not the incident.
Anyway, Meera madam has anything to add?
In paroxysmal AF, like after electrical or chemical cardioversion, how long do you continue the anticoagulation? The guidelines are not very clear.
After, and I didn't get you.
Paroxysmal atrial fibrillation requiring rhythm conversion. And how long do you continue the anticoagulation?
First 4 weeks, you need to definitely continue. After DC version, you need to continue for 4 weeks definitely. And after that, it depends on the CHA2DS2-VASc score and other precipitation factors which are there in the patient. So up to 4 weeks, definitely after DC shock, you need to have aggressive anticoagulation.
When can you discontinue it? That's the question.
No, that's what I said. Long-term management, you need to aggressively monitor the patients for recurrence of AF and also for the underlying triggers. One of the guiding features is CHA2DS2-VASc score. So if the CHA2DS2-VASc score is high, if it is more than 2 in men and more than 3 in women, they need to be on anticoagulation for longer periods, maybe even 4 years, 5 years.
Dr. Nandakumar, maybe the LA size also is, maybe the LA size is also important. That
I mentioned about that. LA size and the LV volume index. LA volume index, sorry. Yeah, the first A in 3 A's which I mentioned is attacking the trigger factors. The first A which I mentioned is that the underlying triggers, they have to be corrected first. No, it was there, sir. It was a little crowded slide.
Thank you. Anyway, we have a crowded hall also. That's a good thing. So all good things must come to an end. Thank you so much. Thanks to both the speakers and the audience for the interaction. We have a literally heavy topic coming up next. Thank you so much.
Yeah, thank you, chairpersons and speakers once again. And now, with much respect and pleasure, once again, let's invite our very dearest Dr. Jayagopal PB, ICC National President, onto the stage, please, to give us an invited talk. Also, I request Dr. Jagan Mohan Taragan, Dr. Venugopal K, and Dr. P.P. Mohanan as chairpersons onto the dais.
Good afternoon and welcome to this very important session of ICC Kerala chapter. It's addressed by none other than the National President of the Indian College of Cardiology, Dr. P.B. Jayagopal. He needs no introduction to this audience as he is already a very senior member of the ICCK and a frontline member of the organizing team of the ICCK. Just a brief introduction of Dr. Jayagopal. He is a director, head and senior interventional cardiologist at the Lakshmi Hospital, Palakkad. More important that he is the person who brought in interventional lab into the district of Palakkad. He is the president-elect of the Cardiological Society of India Kerala chapter. Was the executive member of the National CSI for 6 years and served as associate editor of the Indian Heart Journal. He is, of course, the president of the Indian College of Cardiology now. He is a working group member of the Global Heart Attack Treatment Initiative. He is the Asia Pacific Heart Failure Panel member for Consensus Statement on Heart Failure. He is the principal investigator and national coordinator of the National Heart Failure Registry of the ICC, the first heart failure national registry published from India. He is also a co-investigator in many landmark trials like CREATE, Kerala ACS, ACS Quick, and Heart Failure Quick. And he has several publications in peer-reviewed journals. Welcome, Dr. Jayakumar. And he's going to talk to us on left ventricular hypertrophy, evaluation and management in the current era. Over to Dr. Jayakumar.
Thank you, Professor Taragan and Professor Venugopal for the kind introduction. So I think after a really exhaustive session on very exotic interventions, I thought I would talk on a topic which is probably of relevance to the practicing physicians and what we encounter in our day-to-day practice. I'm really not going to talk about everything about this, but probably a deep dive into what we see when you particularly assess the clinical severity of patients with cardiac hypertrophy. So when you talk about cardiac hypertrophy, we all know that it's a pressure or the volume which produces the changes, which may be either an adaptive. For example, somebody has an athlete has an athletic heart, or a compensatory secondary to hypertrophy, secondary to hypertension. But of course, the common things that we really are worried about the sarcomere mutations, where you have this familial hypertrophic cardiomyopathy and so on, which is probably at the molecular level and the signaling pathways. And that's probably the essence of the talk and what is really difficult to treat. Well, no doubt, I think when you start assessing these patients, the most important thing is the utility of a 12-lead ECG. No wonder that even the guidelines for professional football players is probably to have an EKG to rule out hypertrophic cardiomyopathy, because this is one of the leading cause of death in them. So we go by the LVH, which is striking there, maybe an athlete's heart or a hypertensive heart disease, the apical variant. And in fact, I was fortunate to present the first 7 cases of apical hypertrophy in India, which in the early 90s, which came out in the Indian Heart Journal. But then the very important thing, the subset where you have a low voltage complex, which is typical of amyloid, and of course a short PR, which helps us to differentiate. So the initial clinical evaluation, not going to elaborate, the ECG, echo, and of course the new thing is of course the CMR, and that actually helps us to phenotype this case better. But I think the essence is basically, even today, would be to look at the resting gradients. You want to really differentiate whether it's an obstructive or a non-obstructive, because we all know that an obstructive cardiomyopathy, when there is a resting obstruction, the outcomes are very, very dismal, and probably they have a poorer prognosis. But I think more important, which some of us have started doing in our own hospital, is the genetic testing, and where the phenotyping can also be done along with that. But I think what is more important is perhaps the CMR, which has got one must understand it is a modest correlation with echo, more so with the transthoracic. Can I have a glass of water, please? But I think the more important thing is basically to look at the stress echo, where none of us really keep doing this in our labs, because it's important that you pick up the latent symptoms and the provocable gradient. And also a very important thing, most of us, when you start looking at the echo, we look at the 4-chamber. But I think it's very important that you look at this particular, the 3-chamber, where the LA-LV. And I'll come to it a little later on, because a lot of new things have really come up in this regard. So I start off with a case scenario. This is a 41-year-old lady who came to me. In fact, I have a series of cases, more than 100 cases of hypertrophic cardiomyopathy being followed up. This one lady had giddiness with a family history of hypertrophic cardiomyopathy. Father had sudden cardiac death. Brother was on ICD. Classical clinical HOCM. Holter had no significant arrhythmias. Echo again, classical HCM, myocard, Desiree, SAM. LVOT gradient has gone up from 36 to 64. So that is what it was looking at. Typical hypertrophic cardiomyopathy, nothing much. And you see the gradient was there. I want a little stress again about what you see here in the 2-chamber view, because it is very important that you start looking at the mitral valve there, because there is something which, in fact, I had also coined a name. It was as a namaste sign, which I'll come to a little later on, but then somebody really put in a different name for this and it's often published. Now, over a period of time, as I had mentioned, the gradient started increasing. And mind you, this lady had a familial history of sudden cardiac death. So the question is whether you need, whether she needs an ICD, whether she has to go for a myomectomy or an alcohol septal ablation. And that is where we need to assess, and that's what I thought I'll spend some time on how we would assess. I think it's very important. Today we have access to CMR. We all know that CMR can really give us some ideas, but I think the basic thing was always been looking at an obstruct gradient, which in this case was about 64. And again, the issue is when you have this kind of a gradient, whether it's right to send this young lady to myomectomy or an alcoholic septal ablation. So I think the important thing what we need to understand, this is something which we started, in fact, the first literature which I was a DM student when I started seeing this, and that really generated interest in me. When you look at the mitral valve, there are a lot of abnormalities. The leaflet elongation is probably the most important thing. And today, a variety of surgeons who do myomectomy, they actually look at this in a very, very critical analysis, because what happens if the mitral valve abnormalities are there, you might do a good job. For example, this lady has a gradient of 64. She would qualify for a myomectomy, but then even if you do it, this patient would still have a SAM and an obstruction. Now, why does this SAM happen? That is what I was telling a little earlier, where one should start looking at this from a 2-chamber or a 3-chamber view. When you see this kind of, when the valve collapses, and you find that we wanted to coin a name and put as a namaste sign, but it's known as the nightcap sign today. It has already been published. What you see, if you look at the length of the annulus there, normally it's only about 12 millimeters away from there. In a mitral valve, in a hypertrophic cardiomyopathy, this is often about 24. And because of the Venturi effect, this keeps on hitting it. And that is perhaps the reason of a lot of problems in hypertrophic cardiomyopathy. So I think it's important to recognize this as something which can be easily done. So apart from this, we all keep talking about the thickness of the muscle, the late gadolinium enhancement, the LVOT obstruction. These are important issues. But in this patient, I think the more important thing is to look at LV apical aneurysm with the CMR. It's possible. But one can also critically look at the LA size. Once you find that the LA size increases, these are patients who are probably getting subtle atrial fibrillation, and they are actually susceptible to more problems. But I think my talk is probably to take you a little away from that, also probably to look more in detail to the LV ejection fraction and also the global longitudinal strain, because this really helps us in a big way. So this lady, when we looked at the global longitudinal strain, it was not too bad. And again, the LA volume there, what you see there, it is slightly on the higher side, 40. Again, the question is whether she really qualifies for an ICD. Now the question here, when you have an LV apical aneurysm, we know that today it has been a marker for a very poor prognosis, easily picked up by CMR, but a contrast echo sometimes is helpful. But is there any way in a routine clinical practice that you can do it? In fact, there is an elegant paper which is done on about 121 patients. What you do is you look at the sample volume there, and these are classically seen in patients with thick muscles, not without hypertrophy. These are probably seen in patients with LV significant hypertrophy, and you put a Doppler in the middle level, you find that an echo-lucent area in the center on the right-hand side. There is the Doppler signal has a negative shadow inside. This is very suggestive of an LV apical aneurysm because there is no flow, because it gets sucked into the LV apex into aneurysm. When you find this is a high-risk feature, and these patients can have a sudden cardiac death. Of course, imaging is important not only in that, also for intraoperative TM evaluation. But I think I'll also want to take you to another scenario where this patient had ventricular arrhythmias. The EKG is again very significant changes there. But what is more important, though you find the SAM, there was no LVOT obstruction. In fact, this patient had a significant RVOT obstruction, what you see on the other side. So these are again people who can have really high chance of cardiac events. Now, this is very clear, and in CMR also, there was no late gadolinium enhancement. But the question, and most important, is we are all often worried about ventricular arrhythmias. I think when you look at the literature, this is a study on a large number of patients, close to about 1,000 patients. When you look at the ventricular arrhythmias, we are, really surprised to find that it's not VF, which is very common, but ventricular tachycardia. And in fact, they see that this was only seen in about a very small percentage of patients. And most of these ventricular arrhythmias are actually, an ATP is enough. When you put in an ICD, these are all patients who were integrated with an ICD. More than 1,000 patients, out of which about 200 had an ICD implanted. And they found that none of them really had an excess mortality, and most of them were tackled by an ATP. But more importantly, I think I'm really going to share something about the SHARE registry, which looked into not only the adult but also the pediatric population. This is a large population, 6,000 plus patients with hypertrophic cardiomyopathy adults, 1,000 young patients, and they found that more important factor was the LV function. And what is the LV function difference in hypertrophic cardiomyopathy? It's not the typical LV dysfunction. You categorize them with a less than 50, 50 to 60, or more than 60. The time that you have a LVEF dropping to less than 50 itself, that tells you the all-cause mortality, what you see on the right-hand side, is much higher in patients with hypertrophic cardiomyopathy. So I think a very simple clinical rule, looking for LV apical aneurysm by Doppler, the LV function, all these things are important. Not only that, I think today we are moving into a new era of myosin inhibitors. And there, with all these trials that we have seen, it is important to understand the key thing is to look at the LVEF. Why? Because we know that the gradients might decrease, but over a period of time, the LV function starts going down. And because of that, you find that the moment you have a dip in the LV, less than 50, you are supposed to stop this, interrupt this treatment. So I think it's becoming more and more important. And of course, the CMR has really overtaken as the preferred diagnostic event. Global longitudinal strain, again, is a very important parameter which you need to look into, but then other parameters like an NT-proBNP are really not very helpful. So to make a summary of this, I think the most important thing is to risk factors like age of onset, LVEF less than 50, a GLS less than 80, and of course, the kind of Doppler pattern that I suggested a little earlier. What you must understand, people have started going to look at the papillary muscle level. There are a lot of abnormalities. In fact, the low ones, you find that there is a group where we talk about the apical hypertrophic cardiomyopathy, which is supposed to be a poor, relatively benign prognosis. But you find, look at the apical papillary muscle displacement. If you find that apical papillary muscle displacement, that tells you that these are probably a benign sort of cases. Because in a hypertrophic cardiomyopathy, the typical pattern, this is often at the septal level. Well, if you look at the mechanical function, diastolic physiology, you can differentiate from the athlete's heart. But I think MRI is probably the most important thing. I would like to take you to one of my patients who had an acute pulmonary edema, hypertensive 200/100. We thought it was a hypertensive heart disease, minor coronary artery disease. This is what the LV was looking like, LV hypertrophied. Coronaries were fairly normal. This patient was actually treated with the guideline-directed medical therapy. But then that was the EKG which showed no significant LV hypertrophy. Over a period of time, she started deteriorating. The initial LV function was normal, started getting pericardial effusion, the thick interatrial septum. And this actually, subsequently, when we did that, we found had a typical cherry red spot. I think it's important that we start looking at the global longitudinal strain in these patients. A cardiac MRI confirmed that with the kind of deposits in the space. So I think, so what I'm trying to tell you is that all hypertrophy is not hypertrophic cardiomyopathy. Once in a while you get this kind of disease. But again, you can still go down to use the echo here because there are a lot of parameters at the papillary muscle level in the apical 4-chamber and 2-chamber level. Where you look at the papillary muscle, you can even start picking up amyloid at an early date. But I think it's important that coexistent aortic stenosis also need to be looked into because, of course, we all know the way that you rule out is by a pyrophosphate scan. But in aortic stenosis, when you have an LV hypertrophy, there are a lot of algorithms which are available, which I think it's very important to differentiate because the only treatment which would be useful in aortic stenosis with an amyloid is a TAVR, not a surgical replacement. So I think to conclude, I would say that imaging is a key in diagnosis of hypertrophied hearts. Echo is the primary imaging and that's what is available for every clinician. A lot of things can be inferred even with a simple echo. CMR has changed the approach and it's mandatory. And precision therapy is a buzzword, like oncology. I think it's becoming a precision medicine even in cardiology practice. So precision echo assessment is the future of hypertrophied heart assessment. Thank you all for the kind attention.
Thank you, Jayagopal, for a wonderful overview of the fascinating disease. Hypertrophic cardiomyopathy has been a fascinating disease over the years. And you have stressed the importance of cardiac MR. One more important thing I thought, in the younger generation, younger patients should be genetic studies also.
Yeah, that's mandatory today.
That has to be mandatory. That also need to be stressed when you're following up patients. The moment they cross over 40, the risk of sudden cardiac death actually decreases. So your thrust should be on patients who are younger than 40, all investigation this particular group. And the other thing is the older patient, there is a confusion between hypertensive hypertrophic cardiomyopathy versus HCM. We very often make a diagnosis of HCM, but it might actually be the entity of hypertensive hypertrophic cardiomyopathy.
Yes, sir, I think the SHARE study looked into the 1,000 patients were younger than 18 years of age. 6,000 were older people. And they found the mortality is very high. And the only predictor in a young patient, apart from the thickness, is the LV function again. So the moment you have an LV EF dipping down less than 50 is
and that percentage of scarring is also very important. That 15%, if we have more than 15% scarring,
now,
that is also a predictor of sudden cardiac death. So that is something again which we need to look into all patients with HCM. I feel that all patients with HCM should have a cardiac MR. Even though it may not be practical in all sense. Thank you. Any comments or questions from the floor?
Yeah, that is, and now we have a cutoff value of 18. So if it falls less than 18, you need to really worry about these patients. Yes. Correct.
I think we'll close the session. Thank you for an excellent presentation once again.
Thank you. Now, may I request Dr. Jayagopal to please receive a memento from ICC Kerala chapter, and I request Dr. Jagan Mohan to present this gift to Dr. Jayagopal. Yeah, Dr. Jayagopal and Dr. Venugopal, please. Yeah, thank you. Now let's move on to the next session. And I would like to invite Dr. Mangalanandan P, Dr. Srilekha P, Dr. Krishna Kumar P, and Dr. Srijit A.G. as chairpersons for the next session.
Dear friends, we are running short of time, exactly 30 minutes, and incorporating into the lunch time. So we will rush off things. I invite Dr. C.B. Isaac to talk on NOACs, are they all the same? Should I prefer one? Please.
Respected chairperson, senior colleagues and dear friends, NOACs, are they all same? Should I prefer one? NOACs are considered in the following situations. First, the stroke prevention in non-valvular AF. Second, the treatment of chronic coronary syndrome and peripheral arterial disease in addition to aspirin. Third, the treatment of DVT, pulmonary embolism, and prevention of future DVT. First, the stroke prevention in non-valvular AF, the primary prevention. Non-valvular means in the absence of rheumatic, moderate to severe mitral stenosis, metallic or bioprosthetic heart valve, or mitral valve repair. So, these three were exclusion criteria in the major trials. The term non-valvular is strongly discouraged in the ESC guidelines. because similar benefits were seen in mild valvular lesions also, including mild mitral stenosis, which constituted up to 25% of the patients. Still, RHD-MS was considered unique with a high risk of embolism, so further trials were done. One such trial was Invictus investigators in rivaroxaban and rheumatic heart disease with AF. A recent trial, mitral stenosis valve area less than 2 centimeters square or evidence of LA-SEC or thrombus. They have concluded that vitamin K antagonists led to a lower rate of CV events or death than rivaroxaban without higher bleeding. So indicating that mitral stenosis with AF, vitamin K antagonists are better. Bioprosthetic valve or valve repair was initially an exclusion criteria, but later trials now shows that they are acceptable based on the RIVER trial with rivaroxaban and Inavile trial with edoxaban, recent trials. So we can give NOAC in this situation. Post-TAVI, generally no NOAC, antiplatelet is sufficient, but post-TAVI patient, if they develop atrial fibrillation, popular TAVI trials compared NOAC versus NOAC plus clopidogrel. Only NOAC alone is beneficial. HOCM plus AF, NOAC is safe and effective. AF plus asymptomatic carotid stenosis, NOAC alone is sufficient, no need of antiplatelet agent. AF with intracranial hemorrhage, we can divide into intracerebral bleed and subdural hematoma. Intracerebral bleed, withdraw the NOAC, wait for 4 to 8 weeks, do the imaging. If no hemorrhage, restart. Subdural hematoma and epidural hematoma, surgical evacuation should be done. Then after 4 weeks, we can restart. Subarachnoid hemorrhage is a different group. Try to treat the underlying aneurysm or AVMs and then start the NOAC. In the absence of any remedial etiology, do not initiate the NOAC treatment. In such cases, LA appendage closure may be considered. And patients with AF plus acute coronary syndrome, it's a very important scenario. So 4 prospective randomized trials in all the NOACs were done with NOAC versus VKA with a variety of combination of antiplatelet. The important thing is that these trials focused mainly bleeding as the primary endpoint with coronary events and stroke as secondary outcomes, and they have shown that NOAC plus a P2Y12 inhibitor, 90% cases clopidogrel, 10% cases ticagrelor, decrease the bleeding compared to triple therapy with the VKA. NOAC based dual therapy was underpowered for thrombotic event analysis. And several meta-analyses, a small but statistically significant increase in the risk of MACE when you omit aspirin from the regimen. So if you do a complex PCI or with a history of stent thrombosis, it's better to give a short course of DAT plus NOAC up to 30 days. And in low thrombotic risk cases or a high bleeding risk cases, 7 days DAP plus NOAC is sufficient. Post-ACS more than 1 year, developing atrial fibrillation, it is something like chronic coronary syndrome with AF. NOAC alone is sufficient without an antiplatelet agent. CABG with NOAC, for the first year, single antiplatelet agent plus a NOAC is sufficient. After 1 year, NOAC monotherapy. NOACs in renal failure. Rivaroxaban or apixaban may be preferred. Rivaroxaban from mild renal failure onwards, 15 milligram dose should be given. And apixaban dose 5 milligram can be given and dose can be reduced when the weight is less than 60 or the age is more than 80. There is a new update for apixaban. In hemodialysis patients, we can give apixaban because there is no RCT data for warfarin in AF, severe CKD of hemodialysis. This is a recent trial, renal AF trial, December 2022. Apixaban is better than warfarin in hemodialysis patient. Apixaban is the least excreted in the kidneys. And hepatic failure, only severe hepatic failure is a contraindication for NOAC. LA appendage thrombus, data is available for apixaban and rivaroxaban, while LV thrombus, no data for NOAC. In obese patients, all NOACs are safe and effective up to a BMI of 40 kg per meter square. Above 40, data is less robust, and above 50, do not start NOAC, vitamin K antagonists, and based on the INR, we have to adjust the dose. Low body weight, apixaban need dose reduction if the creatinine is more than 1.5 or age more than 80. Rivaroxaban or dabigatran, there is no dose reduction required. In GI bleed situations, NOACs are not absolutely contraindicated. Preferred agents are apixaban, less bleeding, or dabigatran 110 milligram BD. Avoid rivaroxaban because more bleeding with rivaroxaban. Thrombocytopenic AF patients, there is lower incidence of bleeding compared to VKA, and less than 20,000 platelet count, avoid NOAC therapy. 20 to 50,000, half the dose may be given. Above 50,000 to 1 lakh, proceed with caution, and above 1 lakh we can give NOVAC. In malignancy, similar rates of efficacy and safety with NOVAC versus warfarin. There is primary prevention we have discussed. Now secondary prevention, AF after an ischemic stroke or TIA. If there is a low risk of hemorrhagic transformation, NOAC may be initiated within 3 days in mild stroke, 6 to 8 days in moderate stroke, 12 to 14 days in severe stroke. So within 14 days we can give the NOAC. New data is coming for earlier initiation. This one latest trial in 2023 June, ELAN trial, mild to moderate stroke we can give within 2 days and severe stroke within 6 days. So within 1 week NOAC therapy. Similar results were seen with timing registry also. And now we are coming to the second indication, without atrial fibrillation. Chronic coronary syndrome or symptomatic PAD after revascularization. Secondary prevention of atherothrombotic events. And this is based on the sub-analysis of COMPASS trial and Voyager PAD trial. Here, rivaroxaban 2.5 milligram twice daily in addition to aspirin reduce the ischemic events. But the problem is that both the trials there were higher bleeding risk. So that is the problem with aspirin. And third indication is treatment of DVT pulmonary embolism. We can give apixaban, dabigatran or rivaroxaban. But the more popular one is rivaroxaban because of the Einstein trial. You don't require any bridging with the heparin. Directly start rivaroxaban 50 milligram twice daily for 21 days followed by 20 milligram once daily. Long-term prevention of recurrent DVT pulmonary embolism, post-major orthopedic surgery, low-dose NOVAC, apixaban 2.5 or rivaroxaban 10 milligram. Prevention of recurrent events in malignancy, non-inferior to dalteparin, apixaban is safe and effective. More bleeding with rivaroxaban in GI cancers. And COVID-19 patients, DVT prophylaxis. In hospital, sick patients, we can give low molecular weight heparin. Extended VTE prophylaxis after discharge, it not necessary in all the patient. And biomarker gated management, there is no data. D-dimer based management, there is insufficient data. Pregnancy, NOACs are contraindicated. Pediatric patients, they were excluded from stroke RCTs. Full dose may be given above 50 kilogram. However, in acute venous thromboembolism, there is favorable NOAC data in pediatric, rivaroxaban or dabigatran. So the situation in which vitamin K antagonists are preferred, metallic prosthetic valve, realign trial compared dabigatran versus warfarin, more events with the dabigatran. Rheumatic metal stenosis with valve area less than 2 centimeter square, protein C, proteinase deficiency, Apla syndrome, the vitamin K antagonists because protein C, proteinase are vitamin K dependent anticoagulants and trials with rivaroxaban more events, obesity with BMI more than 50, after gastric bypass surgery, VKS are better, erratic absorption of NOVAC, LV thrombus, no data for NOVAC. Which NOVAC is preferred? No head-to-head comparison in most scenarios. Edoxaban is not available in India. In GI bleed, apixaban, young stroke with low bleeding risk, dabigatran 150 BD or apixaban 5 milligram BD, poor drug compliance, once daily dose of rivaroxaban, dyspepsia, avoid dabigatran, hemodialysis, apixaban. Thank you.
Thank you, Dr. Sibby, for the extensive coverage of the topic. I would like to ask you one question. Is there any indication for lower dose of dabigatran, like, because 110 milligram BD is a recommended dose, but sometimes we use 90 milligram. Is there any is there any recommendation for
You mean 75 milligram?
75 milligram.
Yeah, that is an off-label indication. It is approved in USA only, not in Europe, for renal failure patients. 75 milligrams approved in USA for renal failure patient. It is not tried in major trials, but not approved in Europe. 75 milligram BD.
I can tell an anecdotal instance. What happened is, I had a patient who had a stent and a pacemaker. And after I implanted the pacemaker, I restarted his aspirin and he developed a huge hematoma. So that had to be taken out. So while he was on bed rest, he developed DVT. So I didn't know what to do. So my assistant, Dr. Krishna Kumar, this Krishna Kumar and the other Krishna Kumar started him on dabigatran 75 BD. And the patient went home very fine. No hematomas.
So it is a nice presentation from your side. My question is actually those patients with IC bleed. You told that you'll be restarting the NOAC 4 to 8 weeks later. Will the CT be a guidance for that? And if so, when will you repeat the CT scan?
Yeah, we have to repeat the CT scan. I think it's better to interact with the neurologists. They are the better people to guide us. Because most of the time they will prevent us from starting the NOAC.
Sir, point well taken, sir.
Thank you.
So the flow, I think we'll close the session and start with the next talk, The Art of Wiring a CTO, Step by Step, by Dr. Jimmy George.
Yeah, and I'm just standing in between the lunch and the delay, so I'll just go with that talk. It's an intervention talk, Art of Wiring a CTO, Step by Step. So as you know, the definition of CTO is basically almost a occluded artery of 99% or more than 3 months duration with a TIMI-0 flow. And if you see from the different registries and trials, not much benefit was there, but there was definitely symptomatic benefit, non-worsening of LV dysfunction, as well as a small EuroCTO trial had shown there was greater improvement in the health status too. So a lot of debates are there whether it needs to be opened or not, but definitely a symptomatic patient needs to be treated well. Now if you see from the beginning of last 45 years in intervention from 77 onwards, if you see the first CTO recanalization was done almost in 1978. Then came the different retrograde approaches, different wires, and by the beginning of this century, it was almost seen the newer techniques like the reverse cart, last contrast assistor, all those crossbars, all these came. And the trials came in the later part in the last 10 years, the impact CTO, EuroCTO, REVASC, and decisions. So there was a long process in the last 40 years with the introduction of newer wires, newer techniques, as well as balloons, and even the Stingray crossbar system and all. The JCTO score, the Japanese one, is almost what causes the criteria for getting a tough CTO or a simple CTO. If you have a blunt CTO, long segment, calcifications, as well as a reattempt, all these things make the score more, and as the score increases, the chance of crossing a CTO, the success also comes down. In acute and chronic benefits, I'll just skip this and just go to the wiring techniques. Basically, we have the antegrade wiring, you have the retrograde wiring when you have collaterals, especially septal collaterals. Epicardial collaterals also need, if septal collaterals are not there. Then you got the antegrade dissection in a knuckle wire technique, which mostly are not done now with the better wires and the crossbar Stingray system, that is not there much, as well as the reverse cart system. The main important part of a CTO wiring is the success of the guide catheters as well as guide extension catheters if required. So typical for a right coronary, always an ambulance is a catheter is a choice, if possible, an AL1 or AL0.75, unless an ostium involvement. For the left system, again, for the lady, you can think about an EBU or an XBU. For a circumflex, if you have a roomy left main, still, I think the ambulance would be the better one. Guide extension, as well as anchor balloon supports, are other things which helps to get a better approach for the wires. Now, coming to the components of the wire, like everyone would have an idea about, is basically the core, the covering, the coating, what it taps, as well as the tip. The most important part is the core, what it bakes off. Mainly it's stainless steel. Now we have nitinol, and as well as now we have a combination of all these things, which makes it more flexible, durable, and resilience. So when you want to have a better support, vessel straightening, you need to think about a stainless steel type. And when you need to have lighter support, but more tortuous, more flexibility as well as durability and resiliency, you may have to think about the nitinol things. Now, sometimes you can have the core which is tapering from the middle segment, some only the tip segment. So the less tapering would give you a more lateral support, but the more tapering would give you more flexibilities. So this is how, if you have an acute bend and a prolapse, you need to think about tapering wires. And if you use a microcatheter, that is always better, because CTO is always better to have extra tip load strength when you're using a microcatheter. Now we have the newer Gaia versions. The Gaia Next is going to come by the next few months in India. It was there for the last 5 years in Japan. So they got better 1:1 torque transmissions when you have an external coil, which has got multiple coils surrounding the wire, which gives an extra support. You got a hydrophobic coatings as well known, which gives more lubricity for hydrophilic, especially using for proximal caps, which are not that hard to penetrate, but for penetrating, most probably, you need to use hydrophobic coatings wires. The tip load is the most important part of any wires, especially how much the tip bends is what matters. This is basically a chart of the Asahi wires, and most of the time, in most of the CTOs, if possible, in the not very penetrating one, you can just cross off with the first 1 to 3 grams wire, whether to call it a Fielder XT, anti-gradely and Fielder XTA or XTR, right from the Miracle as well as the UB3, or maybe going up to the penetrating wires like the Conquest Pro, the Confianza, Hornet, and all those. So the different approaches depends on whether you need a low penetrating wire, you need an interpenetrating wire, or you need a high penetrating wire. Always a dual catheter injection is very important for a CTO, and if you have a clear proximal clap, you can think about going with an anti-grade, and swift wire escalation is the most important. Otherwise, re-entry by crossbar Stingray is another option. But if there is no clear proximal cap, think about retrograde as early as possible, and then switch on the wires or switch on dissection re-entry. So stage 1 is basically anti-grade wire escalation if you have a good proximal cap. Think about ADR if possible, if the wire doesn't move to the distal cap. Think about retrograde as another option also when you have an anti-grade failure or when you have an osteal lesions where you may not be visible to get a good stump. And all those post options should be kept in mind when you think about doing a CTO. So this is basically a clear proximal clap. You can have, the morphology is not like a tapered one. So you can use a wire which would cause, because the microchannels are something which are very visible and that needs to be seen on. Unless you have a calcium, you can use wires which can cross these microchannels easily and titrate through the body of the CTO and reach the distal cap. You see over here in the upper one antigrade a convex proximal. It's easy to go antigrade in these cases. And distally, you got a concave distal. So better not to go for a retrograde over there. The one below, you can have both sides are almost curving each other. So you can approach both antigradely and retrogradely in these caps. The third one over there, the proximal cap, it's a convex over there. It's better not to go antigrade in this, and retrograde would be sometimes more easy out. The last one you see over there, the retrograde is almost like a tapered. And sometimes in these cases, it's easy to do a retrograde rather than struggling in the antigrade over here. So this is an example of an LED CTO. You can see the microchannels filling up the mid LED. And if you can use a workhouse wire with a 1 gram tip load, this is a Fielder XT A has got a 1 gram tip load. And you can see that easily it follows the microchannel. You don't need even a microcatheter, it is just a balloon support. And that's the final result. So Fielder wires are good, especially XT is a 0.8 gram tip load, XTA is a 1 gram tip load, and XTR is 0.6. Both are tapered. XTR is basically for retrograde, but still you can try to antigrade out. The other wires especially comes with the Abbott Pilot 50, 1.3 gram tip load, which also has got the feel of going it. Run through is another one out. So microchannel tracking is very important out. This is also same microchannel trapping. This was attempted outside. We had a dissection. After that came up with RCA. This was attempted with a Fielder XTA with a guide support, microcatheter support, and that's the final result. So Gaia series is something especially has got a bend at the tip, which is flattened up, almost comes with 3 series, comes from almost 1.7 to 3.5 to 4.5 gram tip load. Another one in this is a fighter series with 1.5 gram from the Boston. This is basically an ambiguous stump, which is not very visible, but you've got a diagonal over there. XTA did not cross, and this is a Gaia 2, which is penetrating it up. And in the next shot, you can see that the XTA Gaia 2 wire penetrating it up and going distally, and that's the final result in the cranial view. So this is another one, parallel wire technique. You can see the first wire is an Gaia 2, which has gone subintima, and now we've got a Pilot 200, which is penetrating parallel to it. You can see the septals, which have got almost retrograde attempted with a lot of perforations, and that's the final result. So intermediate wires, for parallel wiring like a 3 to 6 grams tip loads are very important up. I'll just skip this. The most important is CT Borio penetration and control drilling is another important part. This is an ISR patient crossed finally with a Conquersport 12 grams. Stiff wires more than 6 grams for basically ISR and long segment body CTO or tough CTO segments. Distal caps, especially when you have in a bifurcation, distal cap is very important. We can go any direction and can cause perforations. So ADR is another option, star technique. This is a Stigner technique. I'll just skip this. And last but not the least, the retrograde attempt. This is an XTR causing a retrograde crossing of a LAD ambiguous stump CTO. And that's the other wires which can be used are the Sean wires, as well as the Sean Black, as well as even the very tortuous one, you can use the SUO3, which is a 0.3 gram tip load. This is a RCA collaterals crossing the LAD, and the next one is crossing the OIM crossing the circumflex. So I would conclude, sorry for the delay. CTOs are time consuming, excess radiation, failure, complications. These we need to keep in mind, but definitely never do it as an ad hoc procedure. You plan well the procedure, supportive guides, dual injections, balloons makes a difference. But wires are the cornerstone, because if you don't cross the wire, the other things won't cross. Escalate the wires as frequent as possible if you think you are getting an obstruction early, and de-escalate it once you have punctured it. IVUS guidance always require, if you have a side branch, keep all the three options. Choose wires wisely. Thank you.
Sir, that was a very excellent presentation. Sir, how does this IVUS helps in wiring the CTO?
IVUS basically, when you have an ambiguous stump, there's no stump visible, and if you're fortunate to have a side branch, like a ramus or an early diagonal in an LED CTO, or maybe like a marginal branch in an RCA, then an IVUS guided puncture is always. But we don't have antegrade looking IVUS, which is available in the Japan from the Thermosite and all, which may come up in the future. But still, on those cases, the side looking IVUS is always beneficial. At the same time, after you cross the wire, to confirm it whether it's in the true lumen, IVUS is very important out to it.
We'll allow one question from the audience. Is there any question? Because already we are running short, we will conclude the session. Thank you, Dr. Jimmy.
Thank you, sir.
Thank you for the wonderful speech. So we are winding up the present session. Thank you.
Thank you, speakers and chairpersons. We just have one more session left in the morning stretch, and let's invite the chairperson for the same, Dr. Prabha Nini Gupta, Dr. Praveen G. Pai, Dr. Ranju Kumar VC, and Dr. Sajir KT.
I'm very honored to be invited to chair this session along with my colleagues. We have two excellent speakers on two really interesting topics. I'd like to invite Dr. Sunita to talk on ultra low volume contrast PCI, which is probably the need of the hour, because we have an increasing number of renal failure patients who need PCI.
Good afternoon. I think it's quite late in the day. First of all, I'd like to thank Dr. Vinod and Dr. Arshad for giving me this opportunity. The question is PCI beneficial in CKD? It has been shown that up to EGFRs of 45, PCI is definitely better for these patients in terms of MACE reduction. And GFR less than 30, the odds ratio is still 0.8, but not significant. Renalism is real. This is quoted by Syed Ali, and he says they found, and this is the editorial actually by article from Dr. Bangalore, And what they found was that in patients with high creatinine, that's creatinine more than 1.5, the need for dialysis within 30 days was 2.1%. So that is the significance of the issue. And the NCDR CAT PCR registry showed that for every incremental 75 ml of contrast use, the risk of AKI increased by 42%. And that is the need for ultra-low volume contrast angiography. Means angiography is performed with contrast as less as 15 to 20 ml, even 10 ml probably. Now, the important thing is the ratio of the contrast volume to the eGFR should be less than 1. And non-ionic isoosmolar contrast has to be preferred. So, it's imperative that you calculate the eGFR for these individuals and use the contrast. Now, who should receive zero contrast PCI? And of course, it is preceded by an ultra low volume angiography. Angiogram, anyway, you need a contrast. eGFR less than 30 ml per minute. Or if the serum creatinine is more than 1.5, with the eGFR is more than 45, then if the ejection fraction is less than 35%, type 2 diabetes, age more than 75 years, recent hypotension and shock. So these are the situations where the kidney gets compromised, or in patients where there's a SCAD, or the spontaneous dissection, where you don't want to inject too much of contrast. Again, zero contrast PCI can be done. And of course, for prolonged procedures like CTOs and bifurcations, where we tend to use more contrast. We have seen the Japanese operators doing CTOs with as less as 25 ml of contrast. Now, how to go on with the ultra low volume contrast? A micropuncture or a Doppler guided puncture of the femoral artery, and good to have a pigtail catheter to get the EDP, because most people now believe that an intra-procedure fluid dose is better rather than a prehydration for 8 hours as we used to believe earlier. And rather than continuously trying to engage, of course, experienced operators know when the catheters engage the ostium. But if you are in doubt, you can inject about 10 to 20 ml of normal saline, heparinase saline, and you will find these repolarization abnormalities. And this is used by many of these, the ardent followers of ultra-low contrast. But you should, you should tell the cath lab personnel that this is going to happen, otherwise they'll get worried. And use a single view and low MAC, no panning. RCA eleocranial is the best. You can see both the proximal as well as the distal RCA. LAD, AP and AP cranial view, and 10 ml of contrast should finish the coronaries, and better to use higher frame rates of 30 frames per second, because then you can see the calcium also very well, and because that is the site oftentimes where the lesion is. And most important, a careful analysis of the angiogram is vital for subsequent zero or ultra low contrast PCI. And avoid multiple exposures and give a washout of 1 week between the angiogram and the PCI, or stage PCI is also better to give a period in between. Now, techniques for procedure navigation, anatomical landmarks would be particularly calcification or high definition IVUS guided, marking wire technique, side branches on the IVUS is a soft landmark, metallic silhouette is a hard landmark, stent boost, live stent boost, and work in the same projection as the CAG. Now, this is a marker wire technique where I have not used this technique. I don't know whether maybe Pratap has used. There's a double Tuhi burst. So you introduce, apart from the first wire, you introduce another marker wire through the side port, and that is kept at the just distal to the lesion. And then the IVUS probe is brought down, and you confirm that the landing zone is good. And then you tighten the Tuhi, and then bring down the stent. After the IVUS and confirm everything, and then see the proximal landing zone, and then the IVUS catheter is removed and the stent is deployed. Now, another technique is a metallic silhouette technique, which we often do. Here is a case of coronary of a circumflex disease, where actually 3 wires are used, one into the small upper OM and into the other 3 OMs, and then the IVUS is used to see and then do the stenting. Now, certain things about wire safety, use knuckle wires so that it doesn't migrate into the branches. And IVUS guidance, always a 7 French guide is better. Lesion length you can get, and stent normal to normal. We know the plaque characters, vessel diameters, and non-disease portion behind the lesion is the distal landing zone. And AKI with this technique is 7.3% still. But remember that CABG has a 4 to 5-fold risk of risk of acute kidney injury compared to PCI. Now, post-stenting run for edge dissection, stent apposition, geographic miss, stent under expansion, MSA, and what the important thing is you cannot identify perforations based on this thing. Now, just talk about a patient, 69-year-old gentleman, diabetic, hypertensive, NSTEMI, his creatinine is 1.6 after 2-vessel stenting, which is zero contrast done by a very dedicated zero contrast operator. And he had a residual lesion in the RCA and with class 2 angina. And he came asking for zero contrast PCI. I said, I can do only a low contrast PCI for you. Earlier people used to come for radial angiogram. So this was a lesion. You can see the proximal RCA, there was a tight lesion, and the distal RCA was also tight, the precrux lesion. This is the angiogram. So guide catheter was engaged without any contrast, and 2 wires were passed. I kept the angiogram in a small WhatsApp video, and then I have the IVUS catheter wouldn't pass, so a small balloon, 1.5 balloon was used to pre-dilate. And then we took the IVUS rod, took both the proximal, the distal artery was 3 millimeters actually, and you can see fibrous plaque sitting over there. And then the proximal RCA lesion was quite surprising because we found a lot of calcium, and you can see almost 270-degree calcium was coming up over there. And the MLAs after pre-dilatations, you can see that the mid RCA was 2.75, and the very proximal RCA it was 1.6. So IVUS really gives insight because on the angiogram it did not appear like that. So the distal RCA was stented with a 2.75 stent, and proximal RCA was pre-dilated and stented with a 3.5 into 38 synergy. It never looked 3.5 on the angio. And post-stenting run showed under-expanded stent in the mid and the osteoproximal part, and yeah, you can see it's like under-expanded. Okay, and then show the diameters. You can see that the diameters post-stenting, the mid RCA was 4.5 and proximal one 4.06, and the very proximal was 7.4. So that was acceptable, but then I had to post-dilate. So we post-dilated again at high pressures. We post-dilated. The other one was before post-dilatation. And then I took one injection. This is a cheat injection. I think it is sensible to do one injection so that you can identify a lot of things like perforations or slow flow, etc. Now, what are the true connoisseurs up to? They are going ischemia guided zero contrast PCI and dynamic coronary road mapping. These are the techniques that are being adopted. But safety considerations are very important because you are going without any contrast or minimal contrast. Monitor the hemodynamics throughout and reserve these procedures for large and clinically relevant vessels. Don't use it for smaller vessels. And a baseline and a post-PCI echo is very important for pericardial effusion because it cannot show pericardial effusion. As I mentioned earlier, one last check shot with 3 ml contrast is sensible. And perforations, slow flow, distal embolization, distal dissections, particularly perforations you cannot identify on zero contrast. And when to go in and do the angiogram, when you have a persistent chest pain, new ECG changes coming up, hemodynamic compromise, if you're using FFR, no improvement in the FFR, or a new and enlarging pericardial effusion. That is the time when you go in and do the angiogram. And this is a study from our own colleague, Dr. Pratap, and 42 patients, mean age of 69, and in complex cases including left main, and also 3 CTOs, and the success was 92.4%. And conclusions, contrast-induced nephropathy is a common complication after diagnostic and therapeutic procedures. Preventive strategies are very important. Aggressive fluid administration and reduction of contrast volume. Advances in imaging techniques will certainly facilitate such interventions, and try to limit contrast as much as possible. And wider use of IVUS is extremely important to decrease the contrast volume and improve the PCI results. Thank you for your kind attention.
It's a really interesting talk, and the case you showed was very interesting. What was the hydration you used in that patient? During the procedure, did you give IV fluid?
Yeah.
with the pigtail? You kept put a
No, no, no.
That's what I was.
Intravenous, intravenous.
So you gave at 16 ml per hour or 16 drops? How many ml per hour did you give?
No, actually,
during
in this
the
patient,
procedure?
in this
During-
patient, I gave 2 ml per.
Okay. What was his ejection fraction? His
ejection fraction was good.
Good. Okay. So, okay. So, the topic is open for questions.
Thanks, madam, for the wonderful talk. Madam, is there any concern of doing something bad for the patient because trying to do for you delineated all the points how we should cross check and all? Is there any incidents that we will do some bad things for the patient trying to avoid contrast?
Well, you may miss dissections, you may miss perforation is the most important. So that's why a constant hemodynamic monitoring of the patient is extremely important. I think the whole team should be geared for that.
Can you explain a little more about that early repolarization when you give contrast, when you cannulate?
That is basically, see, if you want to do zero contrast, what you do is you just engage with the catheter, and when you, to make sure that the catheter is engaged, what you can do is give some saline, hep saline can be injected, and they recommend about 10 to 15 ml. That can be injected, and that will show ST elevations coming in. So then you know that you are truly inside the, we are truly engaged.
Madam, what is your recommendation if some patient requires a calcium treatment like Rota or IV?
Yeah, I think all these cases can be done with rotablation. In fact, if you look at Pratap series, I think Pratap has published the largest series, it's not here, I think, some 44 cases. And you can use any of these modalities. Only important thing is that you don't use contrast. And they also recommend using diluted contrast. And use half contrast and saline. That is also one way of overcoming the situation.
If there are no more questions, in the interest of time, we will wind up. Thank you, madam. Thank you for delineating a good topic. And I will invite Dr. Deepak Davidson for the primary angioplasty tips and tricks.
Good afternoon to all of you, and I would say let me thank the organizers, especially Dr. Vinod and Harshit for having this opportunity. Well, every time we do a primary angioplasty, we do encounter challenges. So I shall take you through a few challenges, how I manage these challenges in my regular practice. To start off, managing the way to the heart, getting the guide catheter to the coronary artery, it's many times difficult in elderly people at least. This was an 83-year-old lady who had tiny radials, calcified vessels, antiwall myocardial infarction, slow flow inside the left anterior descending artery. You could see in the second image that the radial artery is too small, it's tortuous, and it's difficult for you to get a 6 French guide catheter into the radial artery, especially when you have a calcified lesion like this. So we tried going through the femoral approach. You could see that the catheter wouldn't go beyond the bifurcation of the aorta. So we again came back to the radial. We took a 6 French catheter, we wired the radial artery with a run-through wire, and then took a 2 millimeter balloon, inflated it at the tip of the guide catheter, and then we were able to negotiate it through that tortuous small radial artery. So believe me, even in the smallest radial artery, a 6 French guide catheter can be negotiated with this balloon-assisted technique into the heart. Next thing that we had was she had an anomalous subclavian artery. It was arising from the descending thoracic aorta. With difficulty, we were able to engage the vessel. Ultimately, we had to use with lot of difficulties, rotablation, and finally we were able to stent that particular vessel. Now, the next particular situation would be, at times you might encounter surprises like this. This was a patient who presented with an antiwall myocardial infarction, totally occluded left anterior descending artery. In the second image, you could see that the subclavian artery is aberrant. It's arising from the descending thoracic aorta. This is how probably it would look like. This is the CT image on the cath lab. Pigtail catheter inside the ascending aorta. We've taken image. You could see that it's a retroesophageal and it's attached to the descending thoracic aorta. Getting from the descending thoracic aorta into the ascending aorta is at times very challenging. We try to do that with a Termo wire or an O35 wire, and then we try to use a extra backup guide catheter to engage the coronary arteries. Once we engage the coronary artery, things are more or less similar to how you do a regular angioplasty. We cross with the Fielder XT wire, the stent going in, and then finally we were able to achieve a good result. So times you might encounter these sort of challenges. Easy way would be to go through the femoral approach in those situations, or go through the left radial artery in this particular situations. Now, managing the anomalous origin of the coronary artery would be another challenge that we encountered during primary angioplasty. In the past, we always had two challenges, like engaging the coronary artery, secondly trying to get a good backup support for the stent to be negotiated in. Now, with the help of this guide extension catheter, the second challenge is not in fact there at all. You try to engage it, try to get the guide catheter somewhere near the ostium of the vessel, wire the vessel, take a balloon across, over the balloon slide a guide extension catheter into the coronary artery. Once the guide extension catheter is inside the coronary artery, you will be able to easily get the stent across. So this is a patient who presents with an evolved infuval anomalous RC arising from the left coronary sinus. We try to engage it with a Judkins catheter. You could see that it's just remaining at the mouth of the coronary artery. We use multiple wires. The backup support is extremely bad. Now what we could do is get the guide extension catheter into the coronary artery over a balloon, and then over the guide extension catheter you could easily track the stent into the coronary artery, and then get the final results, something like this. So we in our center we commonly use AL1 and short Amplatz left guide catheter, get somewhere near the ostium of the coronary artery, float a wire into the coronary artery, take a balloon inside, inflate the balloon, and then over the balloon take a guide extension catheter, and then things will be much more simpler. Now, how to manage resistant thrombus during a primary angioplasty? This was an young man in full myocardial infarction, tried aspirating. Despite aspiration multiple times, you could see that the vessel is totally occluded. We tried to use a heart rail catheter. This is a 5 French guide extension catheter, 5 French long guide catheter. We took the guide catheter into the coronary artery and tried to aspirate it. Despite that, it was not possible to get the clots out. We thought out of the box and went ahead with a stent retriever that we use for thrombosuction from the brain. That's a stent retriever, and we were able to suck out few clots, and finally this was the result that we could achieve. We could see that with multiple modalities we were able to suck out the clots from the coronary artery, and on day 2 you could see that the flow is very good. We could deploy a small stent over there, and finally we were able to achieve good result in that particular patient. Times there are patients who come with very late to the hospital with organized thrombus, something like this. You could see that there is a huge clot in the proximal right coronary artery. Wiring itself was difficult in this particular patient. All conventional techniques of aspiration failed, so we had to take in the guide catheter. That's a 6 French guide catheter which was introduced into the right coronary artery, and we sucked out the clot, and we were able to achieve a reasonable flow inside the particular vessel. This is another elderly man, 86 years old, evolved anti-wall myocardial infarction, borderline hemodynamics, pulmonary edema. You could see that there is an ectatic segment in the left anterior descending artery with a huge clot sitting there. We tried multiple aspiration, but it was never possible to get out the clot from the coronary artery. So we used a distal protection balloon over there, something like a poor man's distal protection device. Then we used a 5 French heart rail catheter that was taken all the way into the ectatic segment, then aspirated that, and you could see the amount of clot that we could remove from the ectatic segment, and finally we were able to achieve a good flow inside the left anterior descending artery. Now this was another elderly gentleman who presented late to the hospital. He had a huge amount of clots inside the proximal right coronary artery. It was aspirated with thrombosuction catheter. Wiring itself was difficult in this particular patient. We were able to aspirate few amount of clots, but then still you could see that there is significant amount of clots persisting inside the right coronary artery. So we used laser in this particular situation. We used a 0.9 millimeter laser catheter. It was a low energy lacing, which you could see here that after the lacing, the first round of lacing, you would see that the flow is restored inside the coronary artery. Then what we did was we did a directed lacing, that is we used a guide extension catheter so that we can direct the laser catheter towards the clot in a different position, and then again we did lacing. So following lacing for around 15 minutes, you could see that the entire, at least 80% of clots could be significantly removed. The flow is good, and then we did an IVUS evaluation. It was a 5 millimeter vessel. We used a 4 millimeter stent inside that and post-dilated with a 4.5 millimeter balloon, and we were able to achieve good result. But one cannot imagine this sort of results in a huge right coronary artery with a organized thrombus, and but for LASIS probably, this is one niche indication wherein laser would be really helpful, wherein huge amount of clots could be significantly removed. During the procedure, the patient did not have any brady, any slow flow or ECG changes. So laser was really useful in this particular patient managing the thrombus. Well, these are the various techniques of removing addressing resistant clots. Now, how do we manage calcified lesions during acute myocardial infarction? We have three options. Option number one, go ahead, be very aggressive, get a good guide catheter, good guide extension catheter, high pressure balloons, dilate it, and then get away with stenting. This was a tortuous right coronary artery with significant amount of calcification inside that. You could see that we were not able to get the balloon distally despite using a guide extension catheter, but finally we were able to dilate it. Once we were able to dilate it, we took the guide extension catheter deep inside the vessel, and once the guide extension catheter was inside, we were able to get the stent across, so deploy it, and finally we were able to achieve good results. The second option would be to do half work, run away, come back another day, do rotablation and settle the calcific lesions. This was a patient admitted in a nearby hospital, slow flow inside the right coronary artery, inferior wall myocardial infarction. It was undilatable. They were able to achieve TIMI-2 flow, and the patient was referred to us for rotablation, kept on tirofiban for 12 hours. Next day you could see that the flow was good inside the right coronary artery. We did rotablation with 1.5 millimeter burr. There was significant amount of calcification residual there. Then we went ahead with a 2 millimeter burr rotablation, then a stent implantation, 4.5 millimeter post dilatation, and we were able to achieve good results. So that's the second way of managing calcific lesion. The third option would be, if things doesn't work in your way, try rotablation during the acute myocardial infarction, and you might encounter troubles. But then most of the times, even in acute myocardial infarction, when you have less of thrombus burden, you might get away with rotablation. This is another patient, inferior wall myocardial infarction, anomalous arising from the left coronary sinus. We were not able to get a balloon or stent across into that particular lesion, so ultimately we had to go ahead with rotablation. At 200,000 RPM we were able to cross across, then we were able to negotiate the stent, and we were able to deploy the stent. And finally, regarding hypotension, we all know that managing hypotension during myocardial infarction is extremely challenging. So most important thing, one technical point would be, while doing a femoral procedure, always, if the patient has got hypotension, look at the bladder. The bladder should be something like this, but if you have a crescent sign, something like this, if the bladder is pushed towards the opposite side, you know that there is a retroperitoneal hematoma in this particular patient, pushing the bladder towards the opposite side. In those situations, you need to immediately go in with a big balloon, that is an 8 millimeter balloon, occlude the iliac artery, and it usually surprises it that every time you dilate the balloon over there in the iliac artery, within 30 seconds the blood pressure tends to improve, if retroperitoneal hematoma is the cause for that, because I've encountered at least 3-4 times over the last 20-25 years, and inflating a balloon itself, the blood pressure would settle down, and then slowly you need to manage the perforation and settle down. Thank you once again. These are few challenges that we encountered during primary angioplasty, and few solutions. Thank you so much.
Thank you, Dr. Deepak, for the excellent presentation. You have covered almost most of the challenges during primary PCI, and this is, we all come across these type of challenges routinely. Excellent presentation.
How much, what's the anticoagulation dose you gave for that 85-year-old man with that resistant thrombus? Did you give only heparin or tirofiban or what?
Nowadays we use cangrelol in these subset of patients.
Which one?
Cangrelol.
Oh. What's the dose of that? I mean, sorry to
It's
ask.
just 2-hour infusion based on the weight of the patient, approximate weight of the patient.
Okay. So you start cangrelol,
Cangrelol and then aspirin clopidogrel.
You don't give any heparin at all?
Yes, ma'am. Always.
Always?
Always.
Okay. Cangrelol. That's a good thing.
And thank you, Deepak sir, for excellent talk. In your experience, any incidents of acute allergy to contrast during MI and hypotension?
Yeah, not in the recent past. During my post-graduation days while I was in Jayadeva, we used to commonly come across these sort of contrast-related allergies, hypotension and all. But then most of the patients, they ultimately survive. You need to you inject contrast into the coronary artery. There is slow flow in all the vessels, and then they develop cardiac arrest, hypotension. Continue CPR for 20 minutes to 30 minutes. Most of them, they do come out of contrast allergy.
I don't know. Earlier, we used to give 100 milligram F-colon before doing the angiogram, even in an acute MI. There's only one fallacy of that. It seems F-colon takes 6 hours to act. But when we do that, actually, we don't have much contrast allergy.
Yeah.
How did you manage to do the rota early in the morning? Your staff were, there was staff who was conversant with that?
It was 5 a.m. in the morning. It was an anomalous RCA. We couldn't get any balloons or things across. Smaller balloons would go in, stent wouldn't go even with a guide extension catheter. So we thought that we should stop the procedure there, keep tirofiban. But then again, the AV block was there. There was slow flow inside the vessel. So we thought that we should probably try this out, and then it worked.
Okay.
One more question. So what did you put in your rota fluid? Because the patient had heart block.
Ma'am, it's a regular heparin alone. Routinely during rota, we never use anything other than heparin alone inside the rota fluid.
Okay, thank you, Deepak, for that enlightening talk. In the interest of time, we will wind
Thank
it up
you so
and
much.
we'll break for lunch.